अस्सलाम वालेकुम। मैं अफीफा तस्कीन फेमिनिन यूनानी मेडिकल ऑर्गेनाइजेशन की जानिब से आज के इस वेबिनार में आप सबका खैर मकदम करती हूँ। मैं बिना किसी तमहीद के डॉक्टर समिया श्रीन साहिबा MD अदविया, एसोसिएट प्रोफेसर डिपार्टमेंट ऑफ अदविया एंड प्रेसिडेंट ऑफ फ्यूमो से अदबन गुजारिश करती हूँ कि वो एक कॉम्प्रिहेंसिव इंसाइट इनटू PCOD के उन्वान पर रोशनी डालें। डॉक्टर समिया श्रीन साहिबा।
Yeah, Dr. Samiya.
Is she there?
Yeah, she's there. She already joined and she has gone through the mock meeting event.
Yeah.
Samiya, are you there?
Dr. Samiya, do you hear me?
Yes, sir.
Dr. Samiya.
Yeah. Check out if Samiya is there or there is some network problem.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam, Samiya.
Yes, sir. Assalamu alaikum, sir. Welcome you, sir.
Thank you.
Yeah. Is my screen visible, sir?
It's not visible. I think the video is not connected. I think. Your video is not. Others we can see Usman Khan, and I can see other people also, but your video is not connected. Is there any problem? But your sound is there. We can hear you.
Yeah, just a sec, sir. Just a sec.
Check it out first. Before starting your delivering your lecture. And we have some additional sound of other people. I request all the participants to mute their sound so that the speaker will be connected properly. Instead of Oshu, you can mute your sound. Thanks, Usman. I think you got it. If you are having any problem, you can start your lecture and then connect it with yourself.
Is it visible?
No, it's not visible, Samiya.
It's not visible.
There is a sign of plug-like sign instead of your photo.
That's it, sir, actually.
Is it visible?
No, sir, not visible. Yeah, it's now. It's starting now.
Huh?
Yeah. Are you able to see us now?
Yes, I'm able to see. You may proceed, Samiya.
Yeah. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Samiya Shreen. And today, am I audible to everyone?
Yeah. Carry on.
Thank you, sir. Today, I would like to present on a comprehensive insight into PCOS. Okay. And for dealing this topic, I would like to present my topic under these side heads, as you all know. Definitely, we'll get to know about them in detail later on. Now, let us see what is this PCOS. Basically, this PCOS, it was described by Steen and Leventhal in 1935, and later on it was named as Steen-Leventhal syndrome after them. So basically, polycystic ovarian syndrome is a heterogeneous multisystem endocrinopathy in women of reproductive age with the ovarian expression of various metabolic disturbances and a wide spectrum of clinical features such as obesity, menstrual abnormalities, and hyperandrogenism. Now, definitely we'll get to know about it in detail as we'll move later on what are all these terms and how they mean and how they define PCOS later on. Now, coming over to its incidence, this PCOS, it affects 1 in 10 women, and 10% women of childbearing age is estimated to have PCOS, and 50% women are with PCOS are undiagnosed, and 50% women with PCOS are prone to have type 2 diabetes by age 40. And there is 3 times increased risk of women with PCOS develop endometrial cancers, and 5 to 15% of adolescent girls, they develop PCOS as soon after their puberty, and 15 to 20% of infertility cases are due to anovulation caused by PCOS. Here, I would like to stress why this incidence is so important, because it has affected female life in so many different phases. So only this incidence was important. Now, before we get into this topic, let us just deal in detail about, in brief, about what is ovary. Basically, ovaries, they are nothing else, but they are also called as egg receptacles. And these are female gonads, paired structures, and they consist of 4 layers. As you all know in detail about it, but I would just like to brief it about. The 4 layer consists of germinal epithelium, followed by tunica albuginea, which is a dense connective tissue, and then followed by ovarian cortex and ovarian medulla. Now, it is important to know because this ovarian cortex, it contains primary oocytes surrounded by granulosa cells and theca cells. These theca cells, they are present in the medullary stroma. Okay. Next, you see, right, before we understand what is PCOS and how it is, let us go back to the as early as intrauterine life. So at the 5th month of intrauterine life, the oogonia, they undergo the process of mitosis, and they develop or they convert into oocytes, primary oocytes, what we are calling it, and their number is 6 to 7 million. At birth, it is 1 to 2 million, and at puberty, it is 4 to 5 lakh follicles. So what is happening is, over a period of time, there is continuous regression of the follicles. Continuous regression of the follicles, what we are calling it as atresia, isn't it? So now at the time of birth or till puberty, what ovary contains is basically it contains a primary oocyte, which is surrounded by a layer of granulosa cells and a layer of theca cells, isn't it, which are present in the medullary ovulary medulla, isn't it? And that we are calling it as primordial follicle. Okay, so now this primary oocyte, it stops the mitosis and it is ready to enter into meiosis, isn't it, to divide further. But it gets arrested in first level of diplogen stage of prophase till puberty, isn't it? And that further it is not divided. What happens at puberty, this meiosis, it gets released, and then further it is converted to secondary oocyte and first polar body. Okay, so later on we'll understand this, what is its significance. Now, before we deal about the PCOS, I would just like to take a review about the basics, isn't it? As you all know, HPO axis, it is nothing else but hypothalamo-pituitary ovarian axis. It is a very important axis which is related to the female reproductive functions, isn't it? And this axis, though it is present since birth, but it gets functional only at the time of puberty, isn't it? And when it gets functional, this hypothalamus, it releases gonadotrophin, isn't it? This gonadotrophin is nothing else but it is a gonadotrophin releasing hormone which goes and acts on anterior pituitary, and it releases FSH. FSH is nothing else but it is a follicle stimulating hormone. This follicle stimulating hormone, it acts on granulosa cells. If you remember, these granulosa cells are nothing else but these are the cells which are present in the primordial follicle of the ovary, isn't it? So these granulosa cells, on acting upon this FSH, they release estrogen and inhibin, isn't it? They release 2 hormones. One is estrogen and the second one is inhibin. Now, this estrogen, which is released from the granulosa cells, it has got 3 important mechanisms. First mechanism is it has got negative feedback on FSH. That means it decreases the levels of FSH now. And it has got positive feedback on LH. That means it is increasing the level of LH. And on the uterine endometrium, it proliferates the uterine endometrium. That means the uterine endometrium increases in size or its thickness, isn't it? So when there are increased levels of LH, isn't it, that we are calling it as LH surge. Now this increased level of LH, what it does is, it has got three important actions. It acts on the theca cells. Theca cells, again, if you remember, these are nothing else but these are the cells which are surrounding the granulosa cells. These theca cells, they produce androgens, isn't it? These androgens are nothing else but these are androstenedione and testosterone. So how it happens is the theca cells, they produce androgens, and these androgens, they enter into the granulosa cells, and in the granulosa cells, in the presence of enzyme aromatase, these androgens are converted to estrogen. So this is the mechanism how estrogen is produced from the ovary. And basically, the same process, it also takes place in other cells, which are nothing else but adipocytes, which are apart from ovary. Okay, and the two important estrogens are produced, that is E1 and E2. E1 is estrone and E2 is nothing else but estradiol. Now this LH, again, it has got action on granulosa cells also. How it has got action on granulosa cells? Because this LH hormone, it has got its receptors basically on these two important cells. So when it is going and acting on them, when these LH, it acts on granulosa cells, it releases small amount of progesterone, which has got positive feedback on FSH and LH. Now, as these levels of LH increases, what happens? The meiosis, which was arrested in its diploidian stage, now it resumes. What do you mean by resuming of meiosis? That means the primary oocyte, now it gets converted to secondary oocyte and first polar body. And this process, this conversion, we are calling it as ovulation. That is nothing else but the ova is released from the follicle. You see what happens under the effect of FSH, these follicles, they grow, isn't it? We are calling it as follicle stimulating hormone because there are so many follicles which are present in the ovary. So what happens? A set of follicles, they start growing under the influence of hormone FSH. As there is negative influence of FSH by this estrogen, all the follicles, they start to regress except one follicle, and that we are calling it as dominant follicle. And why only that particular follicle? Because it has got maximum number of FSH receptors on that, and it grows and it gets converted into dominant follicle, or we are calling it as Graafian follicle also. That it contains multiple layer of granulosa cells as it increases in size, and it increases in size till 18 to 20 mm in diameter, isn't it? And it contains, again, there are so many names, preantral, antral, there are so many names of the follicles. So what happens ultimately, because under the effect of LH, the Graafian follicle ruptures and it releases a secondary oocyte along with the primary body, isn't it? First polar body. Now what happens? This secondary oocyte and the first polar body, they are swept away, or else they are taken up by the uterine tubes or else the fallopian tubes, isn't it? So now what happens is, what remains is the follicle, isn't it? What remains? The follicle. So that follicle, it gets converted into corpus luteum, isn't it? That corpus luteum, it grows in size again under the influence of LH, and it releases three important hormones, that is progesterone, estrogen, and inhibin, isn't it? So what happens? This again, now you see, this is how the progesterone is released from the ovary. Now this is the second time progesterone is being released, if you have noticed. Now this progesterone in increased levels, it has got two effects. What it does, it has got negative feedback on FSH as well as LH. Okay, that means it reduces the FSH levels as well as the LH levels. Now this, and it acts on uterine endometrium and stabilizes it. You see, initially what estrogen was doing, estrogen was acting on the uterine endometrium and it was proliferating it, but that is not stable, isn't it? So what happens? It can shed at any time. So this progesterone, due to its secretory action, it stabilizes it, or else rather it cements it, isn't it? That process we are calling it as decidualization. So now what happens? Because of this negative influence of progesterone on LH decreases. As LH decreases, corpus luteum also decreases or degenerates, isn't it? As corpus luteum degenerates, all the hormones which are under the influence of corpus luteum, they also degenerate, like progesterone, estrogen, inhibin A, etc., isn't it? So now what happens as the progesterone decreases, the stability of endometrium or the superficial layer is lost, isn't it? If you see what is the histology of the endometrium, we'll get to know that it is divided into two important layers. One is deep and the other one is superficial, isn't it? Deep layer is nothing else but that is the basal endometrium or stratum basalis, we call it as, and the superficial layer is stratum functionalis. So this, whenever there is shedding of endometrium, we mean that it is the stratum functionalis which is being shed off, isn't it? And that shedding of menstruation, we are calling it as shedding of endometrium is called as menstruation, isn't it? So now what happens again, as the estrogen decreases, again there is a positive feedback on FSH. This FSH, again what it does, again its level increases and it acts on follicles again, and the next cycle resumes. So this is how the menstrual cycle it takes place. Till ovulation, we are calling it as follicular phase, and from ovulation till the menstruation, we are calling it as luteal phase. We are calling it as follicular phase because the follicles are growing, and the second phase is called as luteal phase because over here there is a complete deal about corpus luteum. Okay, now this was important for me to review because there are certain mechanisms from this menstrual cycle itself which get affected during PCOS. Now, what happens? One important point over here to note down is that LH surge, which is taking place, it just takes place 48 hours before ovulation, isn't it? And it occurs in the mid-cycle. Mid-cycle in the sense just before 48 hours is nothing else but the 12th day of the cycle. If LH levels are raised in antral cavity from the beginning of the cycle, what it does, it causes reduced mitotic activity of the granulosa cells, and it does not let the granulosa cells to multiply or grow, or it does not let the follicle to grow, it does not let the primary oocyte to grow, and it results in atresia of the follicle, resulting in anovulation. Okay, so this somehow will deal about in detail in the pathogenesis further, but at this level I just wanted to say what is the importance of LH surge, and it takes place in the middle of the cycle, and this LH surge is required for ovulation to take place. Okay, now the hormones, what you need to know, isn't it? So there are so many hormones which are connected with this. You see, the other name for PCOS, what commonly people know, everyone knows, is that it is hormonal imbalance. So to know about it, we need to know about few hormones. I'll just take a very less time and let me brief it up. The important hormone is GnRH, that is nothing else but the gonadotropin releasing hormone, and it is released by the arcuate nucleus of hypothalamus. And where does it act? It acts on the anterior pituitary, and it releases two important hormones or the gonadotropins, that is FSH and LH. Now coming over to FSH, that is the follicle stimulating hormone. It is released by the anterior pituitary, and the receptors are present on the granulosa cells of primordial follicle. Okay, and the third important hormone is luteinizing hormone. It is also released by the anterior pituitary, and the receptors are present on the granulosa cells as well as the theca cells of the follicle. Okay. Now the next important hormone what you need to know about is estrogen. It is important to know about this hormone estrogen because it is only this hormone which increases during PCOS, and to treat this condition also we are going to give the same hormone. So what is this hormone, how does it act, and on which different parts of the body it has got its action, it's important to know. So let us review it. Now this estrogen, the natural estrogen is basically, it is a C18 steroid, and the natural forms of estrogen are basically they are four: E1, E2, E3 and E4. Okay, and these hormones, they change as per the different ages, isn't it? So during the reproductive age, the hormone which is predominating, it is nothing else but it is E2 or estradiol. Okay. So now what happens usually during reproductive age, E2 is more and E1 is less. But in PCOS, what happens? This ratio is reversed and it becomes E1 is to E2 as 2 is to 1. Now, what are the sources from where this estrogen is released? Okay, it is released from the granulosa cells. If you remember, it is also released from the theca cells, isn't it? Because the androgens were getting converted to estrogen, isn't it? And the third important place was corpus luteum, isn't it? The three hormones released by corpus luteum, one amongst them was estrogen. So these are the three important sources of estrogen. Now, how, like where this estrogen is binding? It binds basically to sex hormone binding globulin, as well as it binds to albumin also. So most of the time, the estrogen, it is present in bounded form only, and free form is just only 1%. Now, this is very important. Sex hormone binding globulin, it is increased by estrogen and it is decreased by androgens, insulin, progestin, growth hormone, and cortisol, isn't it? It is important to remember this because, again, this if the level of sex hormone binding globulin is reduced, then it causes increased levels of androgen, free form of androgen, that we'll see later on. Okay, and what are the end products? It is glucuronide and sulfonide. Okay. Now let us see what are the important actions. Though estrogen, it's a very important hormone in almost all parts of the body. It has got some or the other action, but I have selected only few sites. Okay, on uterus, it promotes the growth of the uterus, and on endometrium, it proliferates endometrium. That means it increases the thickness of the endometrium. It increases the number of the cells. And cervix, it thins the cervical mucus. Okay, it helps in thinning of the cervical mucus. And on lipid profile, it increases the HDL levels and decreases the LDL levels, as well as it also decreases cholesterol levels. Therefore, it is cardioprotective. And on LH, the estrogen, it has got positive feedback and it increases levels. And on FSH, it has got negative feedback and it decreases the levels. Okay, now coming over to progesterone, basically it is nothing else but it is a natural form is a C19 steroid. And the synthetic progesterone, it is C21 steroid. It is important to note that androgens are also C21 steroids only. So only synthetic progesterones will have androgenic side effects. Now, these synthetic progesterones, they are available in 4 generations. First, second, third, and fourth. And as the generation increases, the side effects decreases. For example, third generation, they have got least side effects. Examples are desogestrel, norgestimate, and gestodin. And the fourth generation, they are completely anti-androgenic. Okay. And the examples are dosperinone and cyproterone acetate, isn't it? These are important because these are the same drugs which we are going to use to manage this condition. Okay, this third generation and the fourth generation progesterones later on in the form of OCPs. Now, what are the sources of progesterone? The sources of progesterone are granulosa cells, isn't it? And the corpus luteum and the placenta during pregnancy. Now, this progesterone, it binds to cortisol binding protein and albumin, and free form is just 2%. And end products are pregnanidiol and 17-hydroxy pregnanitriol. Okay. Now, these hormones, these end products, they can act as markers, or we can detect them during the cycle at any part, just to know what are the changes taking place in the body. Okay. So only these end products are important. Now, coming over to its actions, on uterus, it promotes growth of pregnant uterus, and on endometrium, it stabilizes endometrium due to secretory action, as we have discussed earlier, isn't it? So if there are reduced levels of progesterone, that means the endometrial stability is less. That means the chances of shedding it of it are more. Okay. And in cervix, it thickens cervical mucus. Okay. And thickens cervical mucus, and on lipid profile, it decreases HDL and increases LDL. It has got a reverse effect of estrogen. And this LH, in low concentration, positive feedback, isn't it, as we have seen before ovulation. And in high concentrations, it is a negative feedback and it decreases the levels, as we have seen on corpus luteum, isn't it? And on FSH, it has got negative feedback and it always decreases the levels of FSH. Now, again, one more important thing, isn't it? Because we have seen that this PCOS, it has got hyperandrogenism. So it is important to know what are the androgens present in the body and from where they are produced. So basically, 3 types of androgens are produced. One is androstenedione, testosterone, DHEA, and DHEAS, isn't it? That is nothing else but sulfate. So the first one, androstenedione, 50% is secreted from the ovary and 50% from adrenal gland. So this is the most common androgen formed by the ovary. Now, when it comes to testosterone, again 25% from ovary, 25% from adrenal glands, and 50% it is due to the conversion of androstenedione, isn't it? In the presence of enzyme 5-alpha reductase. These mechanisms are important because we can inhibit these drugs at any point, isn't it, by using their enzyme inhibitors like that. So enzymes are also important to know. And the normal levels of this testosterone are 20 to 80 nanogram per ml. So what happens when we are talking, the normal levels are important to know because when we are talking, the androgens are increasing, to what extent they are increasing, and when they are increasing, at what level they manifest the symptoms. And the third one, DHEA, that is nothing else but dehydroepiandrosterone and dehydroepiandrosterone sulfate, both are secreted by the adrenal glands. Now, coming over to the etiology of the PCOS, the exact etiology still remains unknown, though there are so many theories which have been postulated, but exact cause is still idiopathic. Now, the PCOS may be influenced by lifestyle changes, diet, genetic factors, isn't it? Obesity, raised androgen levels, sedentary life, stress, insulin resistance, isn't it? We shall definitely deal about this obesity, raised androgen levels, and insulin resistance as we deal with the pathogenesis further. Okay, now when it comes to pathogenesis, let us see what happens basically. There is excessive androgen production from ovary, isn't it? And this androgen levels, they are more than 200 nanogram. Okay, and then when the levels are more, how it features, how it manifests in the form of either hirsutism or male pattern baldness and deranged or dyslipidemia, what we are calling it as, isn't it? Deranged lipid profile we get. Now, what happens in adipose tissue, as I have said you, these androgen levels, they are converted to estrogen in two tissues. One is granulosa cells, and the second one is adipose tissue. So in adipose tissue, excessive androgens convert to estrogen 1 in presence of enzyme aromatase, isn't it? This enzyme aromatase is also important, which is present in the
important.
Okay.
It was important in pathogen.
Now, these PCOS is most commonly seen in obese females. Okay, and then 50 to 70% of females, they tend to be obese or overweight. Okay, as a result of these androgens, what is happening? Ultimately, these androgens, they are getting converted to estrogen in the presence of enzyme aromatase, as we have seen. Now, when these levels of estrogen increase, what do? They have negative feedback on FSH, as we have discussed earlier, positive feedback on LH, and on endometrium. When there is excessive activity of estrogen, it can cause endometrial hyperplasia, endometrial cancers, breast cancers, ovarian cancers, etc. Okay, so now what happens in PCOS, as we have seen, because of negative feedback on FSH, its level decreases and LH level increases. So there is and due to increased LH levels in early phase of cycle, what happens, as I have said you, the LH level is supposed to increase in the mid of the cycle. That we are calling it as LH surge, and that is leading to ovulation. If the levels of LH are increased from the beginning of the cycle or from the early phase of the cycle, then it will have two effects. LH surge is absent because of continuously elevated levels of luteinizing hormone. As a result of that, as I have said you, because LH levels are increased, they decrease the mitotic activity of the granulosa cells, and as a result of that, there is no growth of the follicle. The follicle is supposed to attain a maximum size of 18 to 20 mm to ovulate, isn't it? So there is regression, or else there is decrease in size of the follicles. So only it results in anovulation. And what happens, as we have seen, LH, it has also got receptors present on the theca cells, isn't it? Again, which are present on the follicles. These theca cells, again, what do? Is they increase the levels of androgen, isn't it? As like theca cell hypertrophy is taking place under the influence of LH, again, the androgen levels are increased to more than 200 nanogram. This anovulation, as a result of this anovulation, we have got certain, like it can lead to infertility, isn't it? Infertility, and there is no corpus luteum because there is no ovulation, no rupture of follicle, so no corpus luteum. So no corpus luteum means there is absent or reduced progesterone. And the multiple follicles, now the follicles which are not ruptured, isn't it? The follicles are supposed to get ruptured. The multiple follicles, they appear like, isn't it? And these multiple follicles on USG, they give that necklace pattern, what we are calling it as PCOS. Okay, now just to take a quick glance, the hormones which are increased in PCOS are LH increases, androgens increases, estrogen 1 increases, LDL increases, anti-Mullerian hormone increases, and insulin also increases. And the hormones which are decreased are FSH, progesterone, HDL, and sex hormone binding globulin. It gets decreased. Now, what happens is, in PCOS, number of small follicles are increased in ovary, not regressed due to reduced levels of FSH. And then, no corpus luteum or progesterone causes secondary amenorrhea or anovulatory or irregular cycles, isn't it? As we have seen, like the progesterone is required for the shedding of the endometrium. As there is no progesterone, there is no shedding, and it leads to secondary amenorrhea, isn't it? And one more important pathogenesis which takes place over here is, as we have seen, that obesity, it is a very important cause, and in 50 to 70% of cases, the patients are obese. So what happens due to increased level of adipose tissue? The adipose tissue actually it is considered as an endocrine and immunomodulatory organ, which secretes substances like leptin, adiponectin, and cytokines. So these substances, when their concentration increases, what do? Is they interfere with the insulin signaling pathways in the muscle and liver, leading to insulin resistance. What is this insulin resistance? It is nothing else but it is reduced insulin receptor activity peripherally, isn't it? That means the cells are not able to take up the insulin, isn't it? And as a result of that, hyperinsulinemia results. Now this increased levels of insulin, again they have got increased levels, they increases the level of LH. Again the level of LH, again it causes infertility or miscarriage due to immature development of the oocyte. Again this LH levels, they increase, they cause the theca cell hyperplasia, androgens increase, testosterone increase, and which are ultimately converted to estrogen. So it goes like a vicious cycle, isn't it? Multiple factors basically, they are responsible. You see what happens if a female does not ovulate, as we have concluded that there is anovulation due to raised levels of LH. If a female does not ovulate, no ovulation, no corpus luteum, no progesterone, and no menstruation. Oligomenorrhea. That is nothing else but infrequent menstruation. What happens? You see, we know that the estrogen levels are very important. The estrogen levels are raised. These estrogen levels, they have got the effect on the uterine endometrium, right? And the endometrium is proliferating also, isn't it? Due to high levels of estrogen, but due to reduced levels of and sheds called as estrogen breakthrough bleeding, isn't it? And this is a cause for menorrhagia. Okay. And when it occurs, time period is not known. Okay. You see, initially the patient will have irregular cycles. That means the duration of the cycle is prolonged, leading to secondary amenorrhea. And then, but because the endometrium is continuously proliferating under the high levels of estrogen, we don't know till when it will occur. So, it is a reason cause for irregular menses also. And such cycles, they are called as anovulatory cycles. And these anovulatory cycles, one important indication is that they are painless. Why painless? Due to the absence of PGF2 alpha prostaglandins, which are released under the influence of progesterone, isn't it? Normally, one female, when she menstruates, she feels some abdominal cramps. That is because of the release of prostaglandins, isn't it? Which causes myometrial contractions. Now, because of reduced levels of progesterone, these prostaglandins are also not released. So, these cycles are painless. And the unruptured follicles, which are not ruptured, they appear like cysts on the surface of the ovary, arranged around periphery, giving it a beaded necklace-like pattern. Isn't it? You see on USG. Now, macroscopically, you see if the ovaries are enlarged, and the thick white capsule tunica albuginea, definitely it will also increase in size. The ovarian surface seems lobulated because of the cysts which are present on the surface, and peritoneal surface, it is free from adhesions. And USG shows necklace appearance of ovary, and there are more than 12 cysts. Okay, multiple cysts are there, which are usually more than 12 in number, and the diameter of the cyst should be 2 to 9 mm. and the ovarian size increases to 10 cubic centimeter. Now, coming out to the clinical features of PCOS, if you see, usually as we have seen, it is a disorder of reproductive age, and it is seen in adolescent girls, isn't it? Somehow later on, it will have its complications in the menopausal life also, isn't it? Usually, it is a of young women, usually seen in young women. General obesity will be there. That is, the waistline will be more than 88 centimeter. And then oligomenorrhea will be there as we have seen the cause. Amenorrhea will be there as we have seen the cause. Infertility will be there due to anovulation. Hirsutism and acne will be there due to the reduced androgen levels. Acanthosis nigricans, that is nothing else but it is the thickening of the skin on the nape of the neck and the axillary region that is seen because of insulin resistance. And metromenorrhagia is seen. That is nothing else but irregular menses with heavy bleeding, isn't it? As we have seen, that is because of estrogen breakthrough bleeding which takes place. Okay, now if you see what are the hormone levels, again as we have discussed earlier also, these are the hormone levels which increase, and complications again will deal about it further. Now, what is the diagnosis of PCOS and how will you diagnose? Basically, there is an important criteria, what we are calling it as Rotterdam criteria. And according to this Rotterdam criteria, 2 of the following should be present from the 3, isn't it? Now over here, 3 events are given, and from these 3, any 2 of the following should be present to diagnose PCOS, isn't it? One is hyperandrogenism, and clinically this hyperandrogenism, it manifests as hirsutism. Biochemically increased androgen levels can be seen, and acne can also be seen. And ovulatory dysfunction should be there. Ovulatory dysfunction, how it will be manifested? In the form of amenorrhea, oligomenorrhea, or anovulation, irregular cycles, or menometrorrhagia, isn't it, as we have discussed just now. And on USG, evidences of PCOS either in one or both the ovaries, that is more than 12 follicles are present in the ovary, and the follicular size should be more than 1 centimeter or approximately 2 to 9 mm, isn't it? So if any of the 2 criteria is also present, then also it is diagnosed as PCOS. Sometimes the USG can be normal also, isn't it? Sometimes androgen levels will not be present. So if any of the 2 criteria is present, then we will diagnose it as PCOS. Now, what are the syndromes which are associated with PCOS? There is a syndrome, what we are calling it as hair ant syndrome. That is, HA is hyperandrogenism, IR is insulin resistance, and AN is acanthosis nigricans. All these things are seen in a syndrome, what we are calling it as hair ant syndrome. And apart from that, as we have seen in its definition, that it also causes metabolic disturbances, and it is nothing else but it is an endocrinopathy, isn't it? And it is a heterogeneous disorder. Basically, it involves so many other different functions of the body, it involves them. So that we are calling it as metabolic syndrome, isn't it? There will be obesity, hyperdyslipidemia will be there, hypertension will be there, and hyperinsulinemia will also be there, isn't it? Now, what is the differential diagnosis? As such, it is very easy to diagnose a case of PCOS, but again, a differential diagnosis has to be done. It can be done either with congenital adrenal hyperplasia, because if the adrenal hyperplasia is there, that is also the reasons it can produce androgens. As we have seen, the source of androgens is also from adrenal glands, or else adult adrenal hyperplasia, Cushing's disease, ovarian mass tumors, and hypothalamic or pituitary dysfunction. Now, coming over to the investigations, usually to diagnose a case of PCOS, an ultrasound is considered as a gold threshold investigation, but usually hormonal assays are done very less. In case we have to deal with a case of infertility, we go for the hormonal assays, isn't it? And we go to see, isn't it? If there is insulin resistance, serum fasting glucose levels divided by serum fasting insulin levels, it should be greater than 4.5, then it is considered as insulin resistance. And the serum insulin levels, they should be less than 25 international units. As you know, what are the findings on ultrasound? TSH, serum LH, serum FSH, serum androgen levels, and prolactin levels. All these hormones, usually they are detected. Hormonal assays are done if you have to deal with the case of infertility, isn't it? Otherwise, physiologically, it is easy to diagnose a case of PCOS. Now, coming on to the complications of PCOS, there are two important complications. One is short-term complications and long-term complications. In short-term complications, we have got infertility due to anovulation, hirsutism, again due to raised androgen levels, and irregular cycles due to ovarian dysfunction. And long-term complications, as we have seen about the metabolic syndrome, heart disease can take place, endometrial carcinomas, breast cancers, ovarian cancers. These are all basically due to hyper estrogenic activity. And this diabetes mellitus, it is due to insulin resistance, isn't it? This sleep apnea syndrome is usually seen because of obesity, again metabolic syndrome. All these things, infertility, obesity, leads the patient to depression. And there is so much of dyslipidemia, it can cause non-alcoholic steatohepatitis. Now, what is the management of PCOS? You see, basically for managing the treatment, or when we are going to manage the treatment, the aims of treatments are as follows. First, we have to cure a woman with menstrual disorders. And as the patient is complaining, as per the complaint of the patient, we have to treat, isn't it? Different patients can manifest in a different ways and they present you in a different way. So accordingly, we have to treat. The basic aims of treatment are as follows: to cure a woman with menstrual disorders, to treat hirsutism, and to treat infertility, isn't it? And to prevent long-term effects in the form of metabolic syndrome. So treatment should be as per the requirements. So the first and foremost important thing is weight loss. Weight loss of more than 5% of previous weight, it is beneficial in mild hirsutism, and it restores hormonal balance, isn't it? It decreases insulin level and testosterone level. So weight loss is a very important thing, because obesity is a very important factor which is causing this PCOS. And lifestyle changes, isn't it? Say for instance, if any patient is a smoker, isn't it? The cigarette smoking should be stopped, because this nicotine, it lowers estrogen levels, lowers C2 levels, and it increases the androgen levels. Now, the hormones, third important management will be hormone to regulate the menstruation are as follows. Okay. So you see, if the patient is having insulin resistance, we are going to manage it with the help of metformin. Okay. This metformin, it treats the root cause of PCOS. It rectifies endocrine and metabolic functions. It improves fertility rate, and it is used as insulin sensitizer. It delays glucose absorption and production of glucose in liver. It improves peripheral utilization of glucose, and it decreases the levels of total and free testosterone. It increases the sex hormone binding globulins. Okay, so in case initially how it is started is metformin is given 500 mg daily, and the dose is increases to 500 mg thrice a day. And this metformin, it should not be administered for more than 6 months. In case if metformin is contraindicated due to any hepatic or renal cause, then acarbose 300 mg can be used. And because of this metformin, ovulation occurs in 70 to 80% of cases, and pregnancy in 30 to 40% of cases. Now, you see, if there are irregular cycles, what we are going to use, we are using oral contraceptive pills. These oral contraceptive pills, orals, these are nothing else but oral combined pills, also what we are calling it as. They are combination of synthetic estrogen and synthetic progesterone, isn't it? And there are so many which are available in the market, but when we are choosing, we have to choose preferably the progesterone, which is of third or fourth generation, as it has got less androgenic effects, isn't it? As we have seen, isn't it? Then when it comes to hirsutism also, oral contraceptive pills and this progesterone of third or fourth generation can be used. Now, when it comes to the management of infertility, the first line of management, you see, infertility is mainly because of what? It is mainly because of anovulation, isn't it? So this condition can be corrected. We can induce ovulation. So the first line of management will be the use of ovulation inducing drug. So one such drug is nothing else but letrozole, which is an aromatase inhibitor, oral clomiphene citrate, and the bromocriptine, isn't it? If the patient is having increased prolactin levels also, then we can give this bromocriptine also. And the second line of management will be giving human menopausal gonadotropins, and the patient is not responding to the therapeutic management, then this laparoscopic ovarian drilling can be done, and the theca cells can be destroyed either by using cautery. And the third line of management will be using GnRH in a pulsatile manner. Okay, so how it is like treatment of menstrual disorders, oral combined pills, treatment of hirsutism, third generation and fourth generation treatment of fertility, metformin treats root cause of PCOS, rectifies endocrine and metabolic functions, and improves fertility rate. Weight loss, it increases as I've discussed, lifestyle changes, as well as this ketoconazole. It is an anti-androgenic drug which is used basically it is an antifungal, but it has got anti-androgenic effects, and it also reduces testosterone levels. And sometimes if the patient is amenorrheic, isn't it? So to induce menstruation, progesterone might be used. Okay. So basically, this is how, if dexamethasone is also added 0.5 mg, that also helps in the management of the, that also helps in causing ovulation. Okay. So this was a basic insight, or else a comprehensive insight into PCOS. Hope you have understood what is the, what are the mechanisms, and hope you have understood its management also. Thanks a lot for listening so patiently.
Dr. Samiya Shreen,
Yes, sir.
is there any role of prolactin and thyroxine in this PCOS?
So usually the levels of prolactin are normal
Is there any
in
mechanical
PCOS.
role of prolactin? Prolactin is normal in PCOS, you are telling? Prolactin is normal in PCOS. You are telling that.
Usually prolactin levels are not increased in all the patients. Normally prolactin levels are not increased in all the levels.
I mean, prolactin hormone, it inhibits the, it is also one of the secondary causes.
Yes, definitely. It is also there. Definitely, it is also there. Levels of prolactin are also increased, as you have seen. Hormones which have increased, that I have mentioned about this prolactin also.
Prolactin, nowhere you have told about the physiological functions of prolactin. Just we have included some point in the investigation, right?
Yeah.
So there are some.
Your voice is not clear. I'm not able to hear you properly.
So there are some secondary causes which plays an important role in the PCOS, like hypothyroidism and what is hypoprolactinemia. So these are the some secondary causes.
Yes, definitely. That is the reason it is called as endocrinopathy. That is also the reason it is called as endocrinopathy.
Yes. You did mention that about the thyroxine levels and prolactin levels. Right?
Yeah, basically that is taken up by Dr. Asma. So we have not stressed much on that.
Infertility, PCOS, main prolactin level, it inhibits the FSH and GnRH.
Yes.
Is it? Actually, you should have to mention it. Okay, anyway, nice.
Okay.
Thank you so much.
Thank you so much, Dr. Laukar.
Thanks for sharing your knowledge. You're making us recall that you are, alhamdulillah, you are a mentor. I for all the students, and in fact, the students are posting on the chat that they want your this complete PDF for their studies. So inshallah, we'll share this whole video on our channel. Okay. Now, Dr. Afifa, you may proceed now.
Okay, ma'am. Our second speaker, यूनानी ट्रीटमेंट ऑफ पीसीओडी के उन्वान पर अपने मालूमात का इजहार करने के लिए मैं डॉक्टर फरहा तस्नीम साहिबा BUMS DSG MHM चीफ कंसल्टेंट ZF लेडीज एंड चिल्ड्रन कंसल्टेंट से गुजारिश करती हूँ कि वो अपने ख्यालात का इजहार करें। डॉक्टर फरहा तस्नीम साहिबा।
अस्सलाम वालेकुम रहमतुल्लाहि व बरकातुहू।
वालेकुम अस्सलाम।
फरहात तस्नीम।
मैम
जी बोलिए।
प्लीज लाउडर।
ओके ओके। या अस्सलाम वालेकुम।
यस मैम, वालेकुम अस्सलाम। यस राइट।
या मैं अभी आपको पीसीओडीज के बारे में तो अल्हम्दुलिल्लाह डॉक्टर समिया ने बहुत अच्छी तरीके से उसको पेश किया है। अब मैं आपको उसके यूनानी कॉन्सेप्ट यूनानी पॉइंट ऑफ व्यू से बताना चाहूंगी इंशाल्लाह। जस्ट होल्ड ऑन।
मुझे से
आप लोग ये प्रेजेंटेशन देख सक रहे हैं, स्लाइड्स?
नो मैम।
Not able to see?
Mohammed Zaid, by name Mohammed Zaid?
Yeah.
It's not clear, ma'am.
It's not clear? Just hold on.
Yeah. Now we are able to see, ma'am.
Yeah. तो according to the यूनानी concept, ये जो PCODs होता है इसमें आपको जो है ना ज्यादातर बलगमी मिजाज पाया जाता है। ये इसकी शुरुआत बलगमी मिजाज से होती है और आहिस्ता आहिस्ता जैसे बलगम का एहतराक होता है ये सौदवी मिजाज में तब्दील हो जाता है। सो इसको हम जो है ना पीसीओडीज को हम दबिलतुल खुसैतुर रहम भी कहते हैं या खुसैतुर रहम का छाला भी कहते हैं। ठीक है, तो इससे क्या होता है, पहले तो ये सर्दवतर मिजाज से शुरू होता है।
तो मैम योर स्क्रीन, आई मीन आपका एक्चुअली प्रेजेंटेशन ओपन नहीं हुआ है शायद। We are able to see your group meet screen.
Okay. Slides. Are you able to see now, Dr. Asma? Just let me know.
Yes.
Okay. Fine. Yeah. मैं ये जैसे मैं स्टार्ट करी थी, ये इसको पीसीओडीज को दबिलतुल खुसैतुर रहम या फिर खुसैतुर रहम का छाला भी कहा जाता है। ये शुरू होता है आपको बलगमी मिजाज से। बलगमी मिजाज में आपको सर्द और तर पाया जाता है। ये आपको जो है ना शुरुआत होती है आपके सेडेंटरी लाइफ से, लाइफस्टाइल के चेंजेस से, या फिर जो है ना ग़िज़ाई एतबार से भी आपके बॉडी के अंदर चेंजेस आते हैं और ये जो है ना बलगमी मिजाज आपका तब्दील होते रहता है। जैसे ही बलगम का एहतराक होते रहता है ये आपको जो है ना सौदवी मिजाज की तरफ ले जाता है, जिसकी वजह से आपके पीसीओडीज फॉर्म होते हैं। ठीक है, आपको यूजुअली इसके अंदर आपको जो पेशेंट के कंप्लेंट्स होते हैं इसके अंदर यूजुअली देखते हैं कि जो है ना पेशेंट्स ओबेसिटी रहता है उनको, और ड्राइनेस ऑफ स्किन रहता है, हाइपर पिगमेंटेशन भी रहता है और एडिमा भी हुआ करता है। और पेशेंट्स के कंप्लेंट्स ये होते हैं कि उनका जो है ना वजन बहुत जल्दी बढ़ रहा है और माहवारी का नहीं आना, या फिर अगर आना है तो बहुत थोड़ा आना और फिर बहुत ही तकलीफ से आना। तो ये पेशेंट्स के यूजुअली सिम्टम्स जो है ना कंप्लेंट्स होते हैं। तो और इनफर्टिलिटी भी पाया जाता है इसके अंदर, और जो है ना बालों का बिल्कुल बारीक होना या फिर बालों का ज्यादा झड़ने से पाया जाता है। तो इसके एतबार से हम जो है ना इसको जो है ना सर्द व तर में ले सकते हैं, सर्द व खुश्क में, जिसकी वजह से पीसीओडीज फॉर्म होते हैं। तो इसको हम जो है ना यूजुअली माहवारी के सेकेंड डे से ही आपके फॉलिकल्स के अंदर डेवलपमेंट आना शुरू हो जाता है, क्योंकि इसकी मिजाज के एतबार से जो डॉक्टर समिया ने समझाया है कि आपको जो है ना हाइपोथैलेमस पिट्यूटरी ओवरिन एक्सिस HPOs के जो एक्सिस बता रहे हैं वो एक्सिस जो है ना इसमें तब्दीली आ जाती है, जिसकी वजह से आपके जो है ना फॉलिकल्स पूरी तरह से रप्चर नहीं हो पाते और फिर जो है ना ये सिस्ट फॉर्म हो जाता है। ठीक है, और इसके बाद में अगर हम इसको हाइपरपिगमेंटेशन में लेंगे तो इसके में सौदाई मिजाज का क्लियर कट आपको सिम्टम मिलता है कि जितने भी फोल्ड्स रहेंगे आपके बॉडी के अंदर उसमें आपको हाइपरपिगमेंटेशन पाया जाता है। और जिस्म का फूल जाना इस भी एक जो है ना बलगमी मिजाज का एक जो है ना एतराक की वजह से भी जो है ना इसके अंदर जिस्म का फूल जाना हुआ करता है। ठीक है, अब आगे चलेंगे हम तो देखेंगे कि जो है ना ओव्यूलेशन में इसके जो है ना इसके अंदर दुश्वारी पाई जाती है, जिसकी वजह से आपको माहवारी में आना दुश्वार हो जाता है। अगर आपका ओव्यूलेशन या फिर अगर फॉलिकल्स में अगर कोई डेवलपमेंट नहीं हो, ठीक ना हो, तो आपके एंडोमेट्रियल लाइनिंग भी बहुत ही थिन होती है, क्योंकि इन दोनों का एक दूसरे से इंटरेक्शन होता है। तो इस वजह से आपका माहवारी भी बहुत ही स्कैंटी आती है। तो अब इसमें हम जो डाइट, अब हम जो ट्रीटमेंट की तरफ अगर हम जाएंगे इसके अंदर, तो ट्रीटमेंट में हमको शुरुआत करना पड़ता है ग़िज़ा के एतबार से पहले शुरू करना पड़ता है। तो ग़िज़ा के एतबार से पेशेंट को हम देंगे हॉट एंड लिक्विड डाइट, जो कि जो है ना बिल्कुल जो मुंजिज का काम भी करती है और ग़िज़ा का काम भी करती है बॉडी के अंदर। और हम अगर जाएंगे इसके एक्सरसाइज की तरफ, तो हम बॉडी के अंदर अगर गर्मी लेके लाई जाए या फिर जो है ना उसके अंदर जो है ना हरकत लाई जाए, तो इसके अंदर बहुत ज्यादा ट्रीटमेंट में बहुत ज्यादा आसानी होती है। तो हम जो है ना शुरू करेंगे मेंटल एक्सरसाइजेस की तरफ से। मेंटल एक्सरसाइजेस क्या करते हैं, जो है ना जो HPO का जो एक्सेस है उसको क्लियर करते हैं। मेंटल एक्सरसाइजेस लाइक मेडिटेशन आपको जो है ना मेंटल बैलेंस के लिए हेल्प करता है और बैलेंसिंग ऑफ ह्यूमर में भी बहुत ज्यादा हेल्प करता है। इसमें अगर हम फिजिकल एक्सरसाइजेस के लिए बोलेंगे पेशेंट को, तो बहुत ज्यादा इसमें हेल्पफुल होता है। फिजिकल एक्सरसाइजेस में आपको जो है ना डेली 45 मिनट्स ऑफ वॉक बहुत कंपलसरी होता है, और स्ट्रेचिंग एक्सरसाइजेस की वजह से आपके बॉडी के अंदर जो है ना बहुत ज्यादा हरकत पाई जाती है और गर्मी पाई जाती है, जिसकी वजह से आपके इखलाक में भी तब्दीली आती है। और अगर हम मेडिसिन की तरफ जाएंगे इसके, तो हम उसको जो है ना अगर सब पेशेंट को एमिनोरिया है यानी माहवारी नहीं आ रही है बिल्कुल, तो फॉर लॉन्ग टर्म से माहवारी नहीं आ रही है, तो हम उसको स्टार्ट करते हैं मुदिरात से। मुदिरात में हम उनको देंगे लाइक मगज़े मल्तास, हुल्बा, कुल्थी देकर हम उनको जब जो है ना मुंजिद स्टार्ट करेंगे। तो मुंजिद स्टार्ट ये अगर पेशेंट के माहवारी के 5th डे से हम उसको मुंजिद जब स्टार्ट करेंगे, तो वो जो मुंजिद आपको लाइक बादियान है, हुल्बा है, अनीसून है, गुले सुर्ख है, मुलट्टी है, अलसी है, इन सब का जो शानदार इनको 21 माहवारी के 21 डे तक देने का, 5th डे से स्टार्ट करके 21 डे तक देने का है। उसके बाद में हम उनको देंगे मुस्हिल हम उनको 2 तरीके से देंगे। अगर मॉर्बिड ओबेसिटी है तो उनको 5 दिन की मुस्हिल दी जाएगी, अगर उनको माइल्ड ओबेसिटी है 3 दिन की मुस्हिल दी जाएगी। मुस्लिम में जैसे आपको तुरबुद है, सना है, मुक्ल है, इसके आप जो शानदार से दे सकते हैं, या फिर इसका जो ना सुफू बना करके शहद में मिला करके दे सकते हैं उसको। इसके बाद में अगर हम उसको मुदिर देंगे मुस्हिल के बाद में, तो फिर उनके पीरियड्स रेगुलरली होंगे इंशाल्लाह। और इसके बाद में हम उनको जो है ना एज ए रेजिमिनल थेरेपी हम उनको थेरेपी भी देंगे, जैसे है कपिंग मसाजेस है, उनको डेली बेसिस पे लोअर एब्डोमेन पे कपिंग मसाजेस देना है। और जो है ना आपको उनको कपिंग मसाज के अलावा उनको जो है ना ड्राई कपिंग भी करना है। ड्राई कपिंग आपको उनको जो है ना प्यूबिक एरिया पे और फिर जो है ना राइट इलियाक फोर्सा और लेफ्ट इलियाक फोर्सा में देने का करना है उनको ड्राई कपिंग। एंड फिर उसके बाद हम उनको तो 11th डे एंड 21st डे को हम उनको वेट कपिंग करेंगे, जिससे हम इसको डिटॉक्सिफाई करेंगे। जो भी किसी किस्म का भी जो है ना बलगमी मादा हो जो मुंजिज हो चुका है, जो उसको खारिज करने के काबिल है, उसको हम जो है ना उसको निकालेंगे कपिंग के थ्रू। क्योंकि कपिंग एक ऐसी चीज है जिससे आपको 7 सेंटीमीटर ऑफ डायमीटर तक जो है ना उनको असर करता है, जिससे आप उसको खींच कर मौत को वापस ला सकते हैं। और हम उनको डेली बेसिस पर नुतलात भी देंगे, जिससे उनका जो है ना मोहलिल अगर जो रुतबत है वो जो ना आसानी से कपिंग के थ्रू आ सकती है। और अगर हम मुरक्कबात और ओबेसिटी के लिए हम उनको और ओवरीज के फंक्शनिंग के लिए और एंडोमेट्रियम लाइनिंग के लिए, और अगर किसी किस्म की जो है ना इल्तिहाब हो ओवरीज में, और क्योंकि यूजुअली पॉशम डगलस में आपको पाया जाता है फ्लूइड, तो उसके भी जो है ना ये शरबत बेरन बहुत अच्छी तरीके से काम करता है। तो ये आपको जो है ना आसानी से पीसीओडीज का ट्रीटमेंट हो जाता है इंशाल्लाह। ग़िज़ा में देखिए, आपको ग़िज़ा में आपको बहुत सारी जो है ना तब्दीलियाँ लेके आनी पड़ती हैं। जैसे हमको सर्द ग़िज़ाओं से बिल्कुल परहेज़ करना है इसके अंदर, और सर्द हवाओं से परहेज़ करना है, और क्या आप जो है ना गर्म ग़िज़ा इसमें यूज़ करनी है। जैसे हमको सुबह उठते ही अर्ली मॉर्निंग हम मुनक्का और हनी का जो शानदा और हुलबे का जो शानदा ले सकते हैं, और उसके बाद में हम जो है ना इसको रोजमर्रा के लाइफ में हम आपको उसको चपाती और दाल ज्यादा लेनी, जैसा कि प्रोटीन ज्यादा ले सकते हैं, जिससे आपको तक़वियत मिल सकती है। ये पूरे पीसीओडीज के ट्रीटमेंट के बाद के ये जो है ना ये डाइट चार्ट है इसका। एंड एक्सरसाइज का इसका बहुत बड़ा रोल है इसके अंदर, तो इसको भी हम कंटिन्यू कर सकते हैं। आपका डॉक्टर अस्मा का बहुत बहुत शुक्रिया जो आपने मुझे मौका दिया है इसके बारे में बोलने के लिए और ट्रीटमेंट के लिए। और कुछ क्वेश्चंस है तो आप मुझसे पूछ सकते हैं।
Yeah, everyone. Yes, ma'am, thank you so much for sharing your Unani experience. We have come to know that your Unani practice is very, effective, and alhamdulillah, many patients are being treated. So I'm really thankful for spending your time with us. Are you all able to hear me?
Yeah. Thank you so much, as Dr. Asma, for inviting me at this platform, alhamdulillah. So Dr. Samiya have also given a very good, detailed, structured, and about the ovarian functions. Alhamdulillah. Thank you, Dr. Samiya.
Yes, ma'am.
Thank you, ma'am.
Hello.
Yes, sir.
Who is the next speaker now?
Yeah, we are able to see, sir.
Who is the next speaker?
I'm the speaker, sir. I'm Dr. Asma.
Okay, carry on, Asma, please.
Are you, sir, are you all able to see the screen now?
Yeah, we are able to see it.
I think I don't need to give any introduction of mine. I'm Dr. Asma here. I'm a general physician.
There are few people.
Our third speaker, subclinical hypothyroidism and its impact on fertility. इस उन्वान पर रोशनी डालने के लिए मैं डॉक्टर अस्मा सुल्ताना साहिबा, MD मुआलिजात, जनरल फिजिशियन एंड एसोसिएट प्रोफेसर, डिपार्टमेंट ऑफ माहियातुल अमराज एंड जनरल सेक्रेटरी ऑफ FUMO से अदबन गुजारिश करती हूँ कि अपनी मालूमात से हम सबको आगाह करें। डॉक्टर अस्मा सुल्ताना।
Yeah, thank you, Afifa. Thank you so much. Afifa, is my screen clear to all?
Yes, ma'am.
Okay, we shall proceed now. So my today's topic is basically like the impact of subclinical hypothyroidism on fertility. I mean, like how it's not the subclinical hypothyroidism. We shall see in the near slides like what actually the subclinical hypothyroidism is. But let me clear that this subclinical hypothyroidism, or say hypothyroidism, it's affecting not just the infertility, it's affecting the pubertal age, it's affecting the pregnancy, it's affecting the fetal development. Okay. Okay, so we will have, inshallah, we'll just go through the whole, the impacts of the subclinical hypothyroidism on the various aspects of the reproductive health of a woman. Now, let's have a brief brush up of thyroid gland. As you all know, that it's a butterfly shaped gland, sits in front of the throat, and is responsible for producing the two essential hormones, that's T3, nothing but triiodothyronine, and T4, that's thyroxine. This, the T3 and T4, which is produced in the thyroid gland, is under the control of TSH, that's nothing but thyroid stimulating hormone, secreted by the pituitary, and TRH, that's nothing but thyroid releasing hormone, which is nothing but which is secreted from the hypothalamus. So it's basically hypothalamus sends its signal to the pituitary in the form of TRH, that's thyroid releasing hormone. Now, when this TRH reaches the the pituitary gland, anterior pituitary, the anterior pituitary will be stimulated to release the TSH, that's thyroid stimulating hormone. Now, this thyroid stimulating hormone, via the blood route, it reaches the thyroid gland, and this is responsible for maintaining the structural, the blood flow, and the secretions of the thyroid gland. So this, the TSH and the TRH is basically the stimulators and controlling the thyroid gland. So this was the brief brush up of your thyroid gland. Now, what is hypothyroidism? So before switching on to the hypothyroidism, we know that this thyroid gland, it may undergo the dysfunction. Either it may produce its hormones in excess amount. Okay, we will call it as a hyperthyroidism condition. On the other hand, this thyroid gland may produce its secretions, that is T3 and T4, below the normal range, below the demand of the body, below the requirement of the body. So that condition we call it as a hypothyroidism. So this is basically an underactive condition. It's an underactive condition in which thyroid gland does not produce enough T3 and T4. Clear? Now this, based upon the location, from where, exactly where the error is. So this hypothyroidism is divided into three types: primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism. Now let's see what's the difference between primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism. I hope you all getting me. So, thyroid dysfunction can be of two types: hyperthyroidism and hypothyroidism. If the excess hormone is being produced by the thyroid gland, we call it as hyperthyroidism. And if there is a decreased release of any thyroid hormones by the thyroid gland, it is known as hypothyroidism. Clear? It's nothing but underactive condition of the thyroid gland. Now, you can see here a screen that primary hypothyroidism is basically the dysfunction of the thyroid gland. Okay, though it's being stimulated properly by the hypothalamus and pituitary. It means the defect is in the thyroid gland. The stimulators of it, that is the hypothalamus and pituitary, they are working properly. They are releasing the TRH and TSH respectively very effectively. But the thyroid gland is not in a position to secrete the enough quantity of the T3 and T4, which is the demand of the body. So that condition, when the disease lies in the thyroid gland, responsible for the reduced T3 and T4 secretion, we'll call it as a primary hypothyroidism. Next, secondary and tertiary. Look, secondary and tertiary hypothyroidism is also known as central hypothyroidism. Central because you know very well the hypothalamus and your pituitary, it lies in your central nervous system. Okay, so here the defect will be either in the secretion of TRH or it will be the secretion of the TSH. So here the thyroid is perfect. In secondary and tertiary hypothyroidism, thyroid gland is perfect. But there is something wrong with the hypothalamus. As a result, TRH is not being secreted properly. Or there is some problem with the anterior pituitary, due to which the TSH is not being secreted properly. So that's a major difference between these three types: primary hypothyroidism, secondary hypothyroidism, and tertiary hypothyroidism. I'm repeating, primary is due to the defect in the thyroid gland. Some pathophysiology is lying in the thyroid gland, whereas secondary hypothyroidism is due to the defect in the secretion of anterior pituitary, and tertiary hypothyroidism is due to the defect in secretion of the hypothalamus. Clear? Now, next, I'm just moving towards my topic. I'm precising my the content towards my topic. That's we are now study about the primary hypothyroidism. That's where the thyroid is secreting insufficient hormones. So primary hypothyroidism is basically divided into two types. That's subclinical hypothyroidism and overt hypothyroidism. Now the question is, why? On what basis this primary hypothyroidism has been classified into subclinical hypothyroidism and overt hypothyroidism? It is basically this, you can call it as a biochemical classification. Okay, biochemical classification. Here in the subclinical hypothyroidism, the hormonal levels which is required will be not. On the other hand, overt, if you see the next slide. Now you can here the biochemical change, which otherwise thyroid function. Hypothyroidism is a change in the biochemical ranges of the thyroid hormones, thyroid profile, and it is known as, it is basically a low normal thyroid function. Okay, low normal in the sense, later I have describing detail, like it will be having the normal thyroxine, and but that is the thyroxine या FT4 जिसको आप बोलते हो free tetraiodothyronine या thyroxine, it's basically called thyroxine. It will be in a normal range. It will be within a normal range, but TSH will be raised. TSH will be above normal. What actually happens when TSH increases? It means TSH, it's coming from the pituitary. When TSH increases, so when the stimulus is more, then the production must be more by the thyroid gland. Production of T3 and T4 more by the thyroid gland. But here what is it? Thyroid gland is producing T4, but there are possibilities that in near future, in a few months, a couple of years, this subclinical hyperthyroidism may convert into overt hypothyroidism. Get it? Now you can see the normal ranges of the thyroid profile in subclinical hypothyroidism and in overt hypothyroidism. Overt hypothyroidism in the sense where you can see the clinical manifestations clearly, and the blood profile, the biochemical profile of the thyroid hormones will be this. Look, in both the cases, whether you take the subclinical hypothyroidism or overt hypothyroidism, TSH value is above 4.5. Okay, whereas in nothing with thyroxine, FT4 is nothing but the thyroxine, it is within the normal range in the subclinical hypothyroidism. Whereas in the overt hypothyroidism, it will be less. It will be less than the normal. Whereas FT3 is also within the normal range in the subclinical hypothyroidism, whereas it is less in the overt hypothyroidism. The way, to simplify this whole thing is, just remember TSH will be raised and T3 and T4 will be within normal range in the case of subclinical thyroidism. Now, what causes subclinical thyroidism? Because these days, like I feel next to the diabetes, the most the frequency of the patients we see at the clinic is of hypothyroidism compared to a hyper. Even hypo is more common. So and nowadays the children are being affected more. So the most cause, the first cause, in fact, this in my the causes is autoimmune thyroid disease and the Hashimoto's thyroiditis. Okay, it's this will be inflammation in the thyroid gland, and this inflammation causes the autoimmunity. It's basically an autoimmune disorder where your body produces the antibodies against your own body proteins. Your body producing antibodies against your own body proteins. This is the most common cause. That's why I have listed it to be the first. Second cause is the partial thyroidectomy during head and neck surgery. So if partial thyroid has been removed, that even causes the deficiency in the production of the T3 and T4, though the TSH level will be raised. Next, the use of radioactive iodine therapy in the treatment of hyperthyroidism. Radioactive iodine therapy, look, let's mention, and even most of the students may have this doubt. Okay, nowadays, like, the salt is iodinized. Okay, what is iodine? This iodine, if it is low, it will cause a disease, thyroid dysfunction. If it is too high, then also it causes a thyroid dysfunction. Clear? So when it is low, it will cause hypothyroidism. It will cause hypothyroidism. Now, when it is high, suppose it's given more in the diet or in the form of this radioactive iodine therapy, or it is more in the water, drinking water, then what happens? It will cause IIH, that is iodine-induced hyperthyroidism. IIH, iodine-induced hyperthyroidism. Now, this iodine-induced, it can be hyperthyroidism, it can be hypothyroidism even, because excess iodine, okay, whatever small amount is needed, that is good for the thyroid gland. But when you provide excess iodine in the form of therapy, in the form of drinking water, that's in the form of a salt diet. So this excess, it will damage the follicles, thyroid follicles, and as a result, there will be a deficient production of the T3 and T4. Clear? So iodine in both cases, in deficient form as well as in excess form, will cause the hypothyroidism or hyperthyroidism. Now, next, even certain medications, okay, like even other medicines like amiodarone, interferon, tyrosine, this all thyroid follicles. Next, viral thyroiditis. Even certain viruses may cause inflammation and damage the thyroid gland. And sixthly, it may it may be congenital due to the iodine deficiency during the fetal development itself, and that's called endemic cretinism. Clear? So these are the causes or the etiology of your subclinical hypothyroidism. Next, who are at risk? Who? Which age group, which gender, who are at risk of developing this subclinical hypothyroidism? Okay, so the women are more likely to develop the subclinical hypothyroidism than men, and it is more possible because of the hormone estrogen. Clear? Next, age. With the advancing age, the chances of getting the subclinical hypothyroidism will become more. So as a result, the older individuals are having more chances of getting the subclinical hypothyroidism than your younger ones. In the first gender, you may be confused, like how estrogen is responsible. Like why it's more common in female? Why subclinical hypothyroidism is more common in females? Okay, then I'm giving the reason. Okay, yeah, it's more common in females due to the estrogen. Then the question arises, how estrogen causes? How estrogen is responsible? Look, actually, the FSH, okay, follicular stimulating hormone, it competes with the TSH. It competes with the TSH for its action. It's compete with the TSH receptors basically, okay, for its action. So if FSH is getting chance to work on the receptors, so obviously FSH is responsible for the generation of the follicles, and when the follicles get generated, obviously there will be more secretion of the estrogen. Okay, so this cross reaction between the TSH and FSH, or say the competition between the FSH and NH for the same receptors, may be the cause for its more prevalence in females. And the third predisposing factor is iodine intake, as I already mentioned. Okay, iodine intake, whether you take a deficient intake, then also you are going to suffer from the hypothyroidism. And similarly, when you have excess intake, then also you are going to have either the hyperthyroidism or later finally the hypothyroidism. Clear? Now, how does this subclinical hypothyroidism speaks out? How it manifests itself? So, what are the clinical manifestations, signs and symptoms of this subclinical hypothyroid patient? There will be a dry skin, there will be a poor memory, slow thinking, muscle weakness, fatigue, muscle cramps, cold intolerance, puffy eyes, constipation, hoarseness of voice, hair loss, slow growth and slow sexual development, and irregular menstrual cycle. Clear? So these are the and one thing you not see the all case all manifestations in a single case. Okay, among the 13 or maybe it's still more are there. A few will be present in each case. Now, coming to the main topic, that is the impact of subclinical hypothyroidism on the fertility. So I have here tried to differentiate its impact on the various aspects of the woman's health. Women's reproductive life. That is first its impact over the adolescence, and the next I'll explain in the fertility, the pregnancy, and then fetal development. Now here you can see, okay, as the most prevalent cause of the childhood and adolescence, subclinical hypothyroidism is Hashimoto's thyroiditis, also termed as chronic lymphocytic thyroiditis. Look, what are its impacts of the adolescence, which we'll see in the next slide. But here, the subclinical hypothyroidism, the cause of subclinical hypothyroidism in childhood and adolescence is the Hashimoto's thyroiditis, which is an autoimmune disorder. It is also known as chronic lymphocytic thyroiditis. Here, what actually happens is the lymphocytes get infiltrated or get recruited in the thyroid gland. As a result, they'll damage the follicles and there will be an impaired production of the thyroid hormone. Now, you can see the impact of the subclinical hypothyroidism or impaired secretion of thyroid secretions in adolescence. Clear? In adolescence, the most manifestations is increases of the glandular volume. The size of the gland can easily palpate in the patient. You can easily see in the patient, the size of the gland increases. Next, delayed puberty. Another effect on the adolescent group is delayed puberty, delayed development of the pubertal themes or secondary sexual characters. And sometimes pseudo-precocious puberty can also be seen. That is, what do you mean by pseudo-precocious puberty? Pseudo is like false. Precocious is early development of the puberty. So it's a false development. Now, how can you differentiate between the pseudo-precocious puberty and the true puberty? I'll explain later. But what are the characteristics of the pseudo-precocious puberty? It's nothing. There will be a testicular enlargement in boys and breast development and or vagina bleeding in girls. Okay, but though these changes are pubertal changes, no doubt, in both genders. Okay, but why we are calling it as a pseudo-precocious? Precocious is before the age. Why we are calling it as a pseudo? It's because it lacks the accelerated bone maturation and linear growth, which is accelerated bone maturation and linear growth, which is generally seen in the true puberty. So both the things do not coincide. The male or the female child is developing the secondary sexual characters. There will be a testicular enlargement. There will be a development of the breast or the vaginal bleeding, but there will be no linear growth, no bone maturation in the respective genders. So you can just differentiate with this case. This is a pseudo-precocious puberty, which is due to, again, subclinical hypothyroidism. And usually the female adolescents may experience an associated polycystic ovaries, which alhamdulillah, you have a deep context, both the Unani and the modern aspect by our speakers just now. And look, and the fourth point is nothing, it's very important, which I've already mentioned. The possible association between pseudo-puberty and hypothyroidism is the cross-reactivity between high and high TSH and FSH receptors. It means they both fight for the same receptors. Okay, they both act on the cells through the same receptors. So when the TSH is more, as you know, it is there in the subclinical hypothyroidism. So when TSH is more, so more receptors will be there. So what happened? Though FSH is less in quantity, it will get a chance to act on the receptors. There's the receptor present on the uterus, receptor present in the breast cells, receptor present in the ovaries. So as a result, what happened? The secondary sexual characters start developing, the ovaries, folliculogenesis, follicular development and maturation and the ovulation all take place. As a result, though the child has not reached that age, there is no growth development, bone development, but still TSH and FSH receptor. Now, ये था adolescence का. Now on the reproductive age, okay, where she can bear the child. So it appears in 48% of the reproductive age group. Okay, thyroid hormones are necessary for the proper functioning of the reproductive system. Like it has impact, as I already just now mentioned. It has, the thyroid hormones is required for all the, development of ovaries, uterus, placenta, everything. Please, in the ovaries, thyroxine play a role in the maturation of follicles, ovulation, and the corpus luteum. So we can conclude that this thyroid hormone, the T3 and T4, affecting the complete reproductive life of women. It is not just responsible for the appearance of the secondary sexual characters. It's not just responsible for the growth of the ovary, for the growth of the uterus, but it also responsible for the cyclical changes, monthly changes of a female. That is the ovulation cycle and the menstrual cycle. It's responsible for the folliculogenesis. It is responsible for the ovulation. It is responsible for the development of the corpus luteum. Now, with that, this first question, think how important it is for the pregnancy. Screen that is definitely has that is clinical hypothyroidism. It definitely has a risk over the infertility. It affect the of the patient. Okay, the ovaries may produce because when obviously thyroid hormones are lacking or exactly the deficient, so obviously the patient's ovaries will not perform. There will be no proper folliculogenesis. There will be no prompt ovulation. There will be no maturation of the corpus luteum. So as a result, what happens? There will be in affected women's lower follicular count, lower anti-mullerian hormone, and reduced ovarian disease is reservation than in women with normal thyroid function. I'll just explain you that in my next slide. Okay, this is briefly about what is the impact over the pregnancy. What is the impact of hypothyroidism, subclinical hypothyroidism over the pregnancy? Look, whatever we have studied in this slide, with this we are coming to know that it is becoming an hindrance in the conception. It is becoming an hindrance. This subclinical hypothyroidism is becoming an hindrance in conception. No proper ovulation, no maturation of the corpus luteum will be there, no proper folliculogenesis, even anti-mullerian hormone will be lowered in these cases. So this will definitely become cause difficulty, okay, in the conception. Now, if suppose the patient has conceived, then what is the impact over the pregnancy? In fact, the continuation of the pregnancy. Look, the demand of the thyroid hormone is more in the first trimester, the first 3 months of the pregnancy, than in the second and third trimester. This is due to, because here the fetus is absolutely dependent upon the mother for the thyroid requirement. Because till the end of the first trimester, the fetus thyroid gland is not fully developed to secrete its own thyroid hormone. So for the first trimester, the fetus is absolutely dependent on the mother for the thyroid hormone. So there is a more demand of the thyroid hormone in the first trimester. So mother thyroid needs to be normal for normal fetus development. Look, this what you are looking at your screen is very important. Okay, it's a telltale marker of subclinical hypothyroidism. If you find these levels, okay, in your blood profile, in the patient's blood profile, then you can surely diagnose it to be as a subclinical hypothyroidism. So in the patient of subclinical hypothyroidism, the TSH level will be raised, FSH level will be raised, but AMH level will be decreased. AMH is nothing but anti-mullerian hormone. It is secreted by the granulosa cells of the developing follicle. Okay, so AMH, because of the competence between the TSH and FS, AMH, because folliculogenesis is not being proper, so obviously when the follicle is not properly developed, obviously its secretions will be affected. Now, so follicular count and ovarian reserve decreases. Because of this, TSH, FSH increase and AMH decrease in the AMH, follicular count and ovarian reserve. There. Now this we can conclude that subclinical hypothyroidism investigations. There are very few investigations. Thyroid profile, okay, where you need to check the patient's T3, T4, and TSH. Next is the TPO antibodies. This TPO stands for thyroperoxidase enzyme. Okay, this enzyme is very much important in the generation, in the production of T3 and in the synthesis of the T3 and T4. But in the case of Hashimoto's thyroiditis, or say autoimmune Hashimoto's thyroiditis, there will be an antibody seen in such patients where these antibodies are acting upon this TPO enzyme and degrading it. So, and finally is the ultrasound screening of thyroid gland to rule out any goiter or to rule out any multinodularity. Yeah. So these are the list of investigations which you have to perform in a suspected thyroid patient, whether the subclinical or overt hypothyroidism. Now, what management is there in the modern system of medicine? Okay, the only which you can see here, like in Tylenol, is the only the solution for them. The main treatment goals for hypothyroidism are to reverse clinical progression and correct metabolic deviations. Thyroid hormone is administered to supplement or replace endogenous production. So they have the only single the drug available in the market, which which acts as a supplement or which acts as a the replacement endogenous, which replaces the endogenous production. So this is the only the treatment available in the modern line of treatment for treating the hypothyroidism. Whether you take the subclinical hypothyroidism or the overt hypothyroidism. Now, my question is, does Unani medicine help in preventing overt hypothyroidism from subclinical hypothyroidism? My question is, like, can we prevent or can we regress this subclinical hypothyroidism in its initial stage itself and preventing it from landing into the overt hypothyroidism? So I have discussed with a few of my professors, and in fact, I have used some medicine from Almudin Pharmacy. I have used it on my patients who are all using 100 mcg, 125 mcg Tylenol. So along with that, I have given them that product. So the TSH level was 34 or sometimes 40 was going, and when I was using both the medicines together, the herbal production, Unani product, and the Tylenol, in the beginning, it was like 125 mcg form she was using, and slowly I was side by side decreasing this. So alhamdulillah, in my last course, to be at 0.08 the TSH level. So we can try our better to subside this hypothyroidism at the subclinical hypothyroidism level itself. So these are the few formulations which you can see on the screen, and even which I was using on my patients was also the one of this, that is the ginger and honey together. Ginger and honey together. So in the first Muprad, there are few Muprad Adriya, single drugs like Barge Kachnal, it's nothing but orchid tree. It's called also called Monty Eboli. Okay, so it is basically it's easily available around us. It's very easily available around us. Its scientific name, botanical name is Bohemia variegata, and it belongs to the family Fabaceae, and it has a number of health benefits. But here the question is, how it's working in treating your subclinical hypothyroidism. In what form you can give? The very first thing is you have to take the leaves of the Barge Kachnal, and you have to make a pill in the juice of adrak ke ras mein milakar gulliyan banane and give the patient morning evening. Okay, so this Kachnal, Bohemia variegata is a anti-goitrogenic. Okay, it's an anti-goitrogenic. So its ethanolic concentrations, has this anti-goitrogenic effect when given in 200 milligram per dl. And it has a very neomercazole-induced hypothyroidism, neomercazole-induced goitrosis. Okay, and it is also an immunomodulator. So it can be given in your Hashimoto's thyroiditis or autoimmune thyroiditis. immunomodulator, and it is an anti-inflammatory also. So these three important features. One is anti-goitrogenic, second is immunomodulator, and third is anti-inflammatory. Okay, so with this property, we can use this in your clinical hypothyroidism as well as in overhypothyroidism. The next important medicine is adrak, ginger. Okay, it's gingiber officinalis. Okay, it's okay. So adrak इसमें आपको करना क्या है कि अदरक का रस और 50 gram you have to take the ginger and mix 100 ml of water in it and grind it together, and then take 10 to 20 ml of this ginger juice and mix it with the 10 ml of the honey, and you have to give in the morning. Clear? Before breakfast. And even this kachnal tablets also in the before breakfast. Second, the most potent. Okay, even it has come to know that the leaves of the kachnal, more than the leaves of the kachnal, its potency is more in the bark of a kachnal. दरख्ती कचनाल की छाल होती है उसमें वो ज्यादा बहुत पोटेंट है कंपेयर टू द लीव्स ऑफ द कचनाल. तो इसका जोशानदार भी आप मॉर्निंग नहार पे दे सकते हैं पेशेंट को. या you have मस्तगी रोमी, okay, 1 gram, and along with that ज़ाफ़रान 1 तोला, ये दोनों को मिलाकर ये भी नहार पे दिया जा सकता है. Look, let me just have I'm going too long, but I'm about to finish now. But let me have a brief, the overlook over this gingiber officinalis or ginger. This ginger is basically, it has different compounds like gingerols and shigols. This gingerols and shigols, and it has various other active compounds, which is a pharmacological property similar to NSAID, that is non-steroidal anti-inflammatory drug. Okay, this gingerols and shigols, is having the pharmacological property similar to that of your NSAID. Okay, so it means it inhibits the synthesis of the prostaglandins and leukotrienes by suppressing 5-lipoxygenase and prostaglandin synthase. You know very well, anti-inflammatory chemical mediators हैं ये, and so these, this ginger, it inhibits the anti-inflammatory chemical mediators in a simple way, and does help in preventing inflammation. Okay, and next there are certain murakkab also, compound formulation, patient people do we do what which is article, after breakfast. And this 5 gram along with about 1/4 gram you can give at bedtime. And the wall kurkum kabir, if it is very if its pH value is quite high, then you can add up to the wall kurkum kabir 5 gram at bedtime even. So thank you all. This was I have tried myself best to concise the topic. Its impact subclinical hypothyroidism on the aspect of reproductive life of a female. Thank you all. Thank you for giving us time. Yeah, to you. Yeah, Dr. Afifa.
Yes, ma'am.
You can proceed.
थैंक यू मैम. इसके बाद में एक ऐसी शख्सियत जिनके हाथों में अल्लाह ने शिफा और जुबान में तासीर रखी है, हमारे मुरव्वी व मुशफ़िक़, आज के चीफ गेस्ट एंड चीफ स्पीकर. इनसे मेरी मुराद जनाब डॉक्टर एहसान फारूकी सर, प्रिंसिपल गवर्नमेंट निज़ामिया तिब्बी कॉलेज एंड जनरल हॉस्पिटल एंड एडिशनल डायरेक्टर डिपार्टमेंट ऑफ आयुष. सबसे पहले तो मैं डॉक्टर अस्मा सुल्ताना और फ्यूमो के तमाम मेंबरान आपके तहे दिल से ममनून और मशकूर है कि आपने अपना कीमती वक्त आज के इस वेबिनार में दिया. मैं सर से अदबन मुल्तमिस हूँ कि यूनानी पर्सपेक्टिव ऑफ गायनोकोलॉजिकल डिसऑर्डर्स के मौजू पर अपनी मुफीद मालूमात से हम सबको गोशगुजार फरमाएं. डॉक्टर एहसान फारूकी सर.
Okay, sir. Myself, Dr. M.A. Farooqi, Government Design Studio. And Alhamdulillah, there are few presentations from Samiya Shreen, and she has excellently presented the oogenesis, the action of the FSH, LH, and progesterone, molecular phase as a luteal phase, and gonadotrophic hormone also, and the what is called progesterone, T19 and T21. Alhamdulillah. And the next presentation is from Farha Tasneem of the Unani concept of what is called the PCOS or level best in treating what are called PCOS with Unani system of medicine. And as far as allopathy is concerned, and somehow or somewhere they are having their own limitations in treating PCOS with their own drugs. And unfortunately, the most of the we are not supposed to criticize any system at all, especially allopathy, because every now and then we uses allopathy medicine for our own concern. But unfortunately, most of the allopathic drugs are causing their side effects. Now, there are a few questions which I am presenting in front of you people. Number one point is how far we have succeeded in creating PCOS with Unani system. Number one question. Number two, what is our own concept about mizaj and akhlaq, and can we clearly define them in connection with disease? This disease. Number three, the importance of this disease in connection with thyroid, obesity, infertility, and of course what is called psychiatric problem and acne and cosmetic problem, as we have discussed earlier also. Now the problem is that unless and until we are we don't connect it with what is called amraz सादा और amraz what is called जहाँ पर हम ये कहते हैं मतलब कि अगर किसी मिजाज के साथ अगर एसोसिएट होता है या किसी आपके अखलाक के साथ अगर एसोसिएट होता है तो उसे हम कहते हैं माफी कहते हैं. जैसे डिसीज का जो क्लासिफिकेशन है बेसिकली अमराज सादा. आपने जब मौलियत में जब आपने अमराज हुमा पढ़ा था तो एक कॉन्सेप्ट है, मोस्ट प्रोबेबली आप यू नो अबाउट इट, एक हुमा एक रोजा के नाम से एक मतलब के एक चैप्टर हुआ करता था. जैसे हुमा फिक्रिया है, फराइया है, फजाइया है. ये जो हुमा एक रोजा होते हैं ये अमराज मादी नहीं होते. मादी के माने क्या है कि मतलब कि जहाँ मादे का गलबा हो. सर्दी जुकाम एक आध दिन की होती है तो हम वी कैन नॉट टर्म इट एज ए अमराज मादी. अगर किसी को कमर में दर्द होता है तो वी कैन नॉट टर्म इट एज ए अमराज मादी. अगर किसी को सर दर्द होता है तो वी कैन नॉट टर्म इट एज ए अमराज मादी. अमराज मादी के माने के क्रॉनिक एलिमेंट. अभी आपके सामने जब अस्मा ने आपने हाइपोथायरॉइडिज्म थायरॉइडिज्म के बारे में प्रेजेंट किया और यूनानी कॉन्सेप्ट भी प्रेजेंट किया गया और सामिया श्रीन की तरफ से इन डिटेल प्रेजेंटेशन हुआ. तो इसके अंदर हमें ये समझना जरूरी है कि किसी भी मर्ज जैसे डायबिटीज हो, हाइपरटेंशन हो और मतलब के कोई क्रॉनिक मर्ज हो, जैसे फॉर एग्जांपल साइकेट्रिक प्रॉब्लम्स हो, तो हमें इन अमराज की तकसीम को जज करना है, फाइनलाइज करना है, पिन पॉइंट करना है कि ये बलगम की वजह से है, ये सफरा की वजह से है, ये खून की वजह से है, या सौदा की वजह से. सबसे पहली चीज हमें ये जानना जरूरी है. और दूसरी चीज ये कि मतलब के जितने भी आपके थायराइड के डिसऑर्डर्स होते हैं या पीसीओज होते हैं तो ये ऑब्वियसली दे रन फॉर ए लॉन्ग टाइम. एंड इसका जो इफेक्ट है बॉडी के ऊपर बहुत ही ज्यादा ड्रास्टिकली है. ड्रास्टिकली इन द सेंस दैट अभी आपके सामने डिस्कस किया गया कि मतलब कि ये सिर्फ आपके स्किन के एलिमेंट्स लाती है, ये बल्कि आपके क्या कहते हैं कॉस्मेटिक प्रॉब्लम लेकर रहती है, ओबेसिटी लाती है, थायराइड प्रॉब्लम लाती है, इनफर्टिलिटी. तो मेन सबब बनता ही है. और बहुत से ऐसे फीमेल जो सफर होते हैं वो साइकेट्रिक प्रॉब्लम से सफर होते हैं बिकॉज दे कैन नॉट कंसीव एंड अल्टीमेटली रिजल्ट इन ऑडिबल साइकेट्रिक डिप्रेशन एंड समटाइम्स क्रॉनिक एलिमेंट ऑफ सौदा आल्सो. तो यहाँ पर अभी डॉक्टर फरहा ने कॉन्सेप्ट दिया था, मतलब कि हम सभी लोग इस कॉन्सेप्ट को मानते भी हैं कि और ये है कि बलगमी कॉन्सेप्ट की वजह से ये प्रॉब्लम होता है. और बलगम के एहतराक की वजह से जो सौदा होता है तो ऑब्वियसली इफ दिस प्रॉब्लम व्हाट इज कॉल्ड सर्वाइव फॉर ए लॉन्गर पीरियड, और ऑब्वियसली बलगम का एहतराक होगा और सौदा में बलगमी में कन्वर्ट हो जाएगा. और सौदा में बलगमी में कन्वर्ट होने की वजह से पेशेंट को मतलब के ये सारे मतलब बलगमी सौदावी अमराज का क्लिनिकल साइन सिम्टम्स पाए जाएंगे. तो यहाँ पर सबसे अहम बात मुझे ये करनी थी, कंक्लूड ये करना था, सबसे अहम बहुत जरूरी था, और वो ये है कि मतलब कि कांट वी मेक एन इंटरनेशनल पीसीओ रिसर्च फोरम, इंटरनेशनल पीसीओ रिसर्च फोरम फ्रॉम यूनानी साइड. It's a very, very important point to be raised from my side, and it has to be considered as most important what you call program in the days to come. और दूसरी चीज ये है कि मतलब कि अनफॉर्चुनेटली हमारे पास जैसे मॉडर्न मेडिसिन के अंदर जितने मतलब कि आप जितने भी इनफर्टिलिटी सेंटर्स खुले हुए हैं और जो नए नए मतलब कि आर्टिफिशियल इंसेमिनेशन किए जा रहे हैं और ये सारी चीजें की जा रही हैं, लेकिन अनफॉर्चुनेटली थ्रूआउट वर्ल्ड गोल्ड इंडिया हैदराबाद के अंदर हो या कहीं और भी हो, देयर इज नो सच मेडिकल साइंस और डॉक्टर्स ऐसे मौजूद नहीं है जो यूनानी की तरफ से आई मीन इनफर्टिलिटी का ट्रीट करते हैं, यूनानी की तरफ से पीसीओएस का ट्रीट करते हैं, यूनानी की तरफ से थायराइड का ट्रीटमेंट करते हैं, और ये चीज हाईलाइट होना जरूरी है. जस्ट नाउ आज मॉर्निंग के अंदर मेरे एक डॉक्टर आए थे, he came from Bombay and he came to me to go for what you call manufacture. So he is what you call, he told me that मतलब फॉरम सर मैंने इंटरनेट पे सर्च किया, काफी सर्च करने के बाद आपका नंबर मिला, and why don't you people what you call do the advertisement in what you call internet for all these diseases, for all these treatments, for all these procedures which you are doing and which is giving and what you call most what you call important results in treating the chronic disorders. So marketing is very important, and marketing के अंदर unfortunately we are far away from what you call prime marketing procedures and prime marketing methodologies, and we need to do what you call जितनी अच्छी मार्केटिंग हम कर सकते हैं करना चाहिए, और जरूरत है आज की मार्केट के अंदर कि मतलब कि इन तमाम चीजों को हमको हाईलाइट करना जरूरी है. और दूसरी चीज एक क्वेश्चन आया था कि मतलब कि हाइपरप्रोलैक्टिनिमिया इन पीसीओएस के बारे में आया था, तो मतलब कि यहाँ पर एक चीज ये कि मतलब कि एनिवलेशन इज इन वुमेन, मतलब कि ओवुलेशन नहीं होना वुमेन के अंदर दो वजह से होता है, एक पीसीओएस की वजह से, एक प्रोलैक्टिनिमिया की वजह से होता है. और पीसीओएस के मतलब पॉलिसिस्टिक ओवरियन सिंड्रोम के अंदर देयर इज व्हाट यू कॉल मेन रोल जो भी है वो प्रोलैक्टिन का भी है, जो क्वेश्चन का मुझे थोड़ा सा आंसर भी देना था, इसके लिए मैं इस चीज के बारे में कह रहा था. और दूसरी चीज ये कि मतलब कि मैनेजमेंट के ऊपर डॉक्टर फरहा ने बहुत अच्छी बात कही, मतलब कि हमें मुंजिज देना चाहिए, मुंजिज कितने दिन देना चाहिए और मुश्किल कितने दिन देना चाहिए और तबरीद कैसे करनी चाहिए. बलगम का उस एक प्रिंसिपल है कि मतलब 3 वीक तक मुंजिज देना चाहिए, और माउल असल भी दिया जा सकता है जैसे पैरालिसिस के अंदर हम ट्रीट करते हैं. और एक चीज ये है कि मतलब कि यूजुअली हमारे जो बॉडी के अंदर जो इस्तेहाला मतलब कि मेटाबॉलिक जो चेंजेस वाक़ होते हैं वो एग्रीवेट किया जा सकता है, मतलब कि उसको स्टिमुलेट भी किया जा सकता है विथ व्हाट यू कॉल मतलब कि 1-2 दिन या 3 दिन का हम अगर किसी फास्टिंग रखते हैं तो उससे बहुत ज्यादा चेंजेस आ सकते हैं, और मवाद एहतराक की तरफ, मवाद खारिज होने की तरफ राग़िब हो जाता है. तो थोड़ा सा ये कॉन्सेप्ट ध्यान में रखें, मतलब कि जैसे हम पैरालिसिस का ट्रीटमेंट करते हैं, और वी नीड टू व्हाट यू कॉल फिक्स द डिकॉक्शन, मतलब कि जो मुंजिज का जो पीरियड है उसको फिक्स करना जरूरी है एज पर द रिक्वायरमेंट ऑफ द डिजीज, एज पर द रिक्वायरमेंट ऑफ फ्रॉम इंडिविजुअल आल्सो. और अनफॉर्चुनेटली क्या होता है मतलब कि हम लोग एक बंधा टका उसूल ले लेते हैं, मतलब कि जैसे फॉर एग्जांपल ये बात है कि मतलब कि डॉक्टर अस्मा सुल्ताना की तरफ से बात कहते हैं कि मॉडल के अंदर क्या है थेरानॉम दिया जाता है. तो माय क्वेश्चन इज टू बी आवरसेल्फ, मतलब कि मैं अपने खुद को ये लिए कॉल करता हूँ या आप तमाम के सामने भी रखता हूँ कि थायराइड के लिए मॉडर्न मेडिसिन के अंदर थायरोनॉम जो दी जाती है, 25 मिलीग्राम दिया जाए, 12.5 मिलीग्राम दिया जाए, 50 मिलीग्राम दिया जाए, 75 मिलीग्राम दी जाती है, 100 मिलीग्राम दिया जाती है, 12.5 मिलीग्राम दी जाती है. Is there any end? Is there any end for what you call prescription? There is no end at all. मतलब कि आप ये जो ट्रीटमेंट देते हैं हाइपरटेंशन का, डायबिटीज का, थायराइड का, ये सारी चीजें जो दी जाती हैं वो ट्रीटमेंट के लिए दी जा रही है. ट्रीटमेंट किसे कहते हैं? मैंने गोली खाई, आपसे बुखार कम हुआ. अब ये तो मतलब ये बुखार ऐसा बुखार है कि मतलब कि ये साल तमाम हमारी जब तक हम खबर में नहीं चल जाती, ये बुखार चलता रहेगा. हमें पैरासिटामोल खाते रहनी पड़ेगी, हमें थायराइड की गोली खाते रहनी पड़ेगी, हमें हाइपरटेंशन की गोली खाते रहनी पड़ेगी, और हमें शुगर की गोली खाते रहनी पड़ेगी जब तक कि हम मतलब कि हम आखिरी वक्त तक नहीं पहुंच जाते. आई डोंट थिंक दैट मतलब कि दिस इज अ ट्रीटमेंट एट ऑल. Unfortunately, we need to come out with a good formulation so that thyroid can be treated permanently. Number one point, or PCOS can be treated, and so can the individual can achieve it and achieve करे और PCOS खत्म हो. ये जरूरी है मतलब कि we should come out with a formula. We should come out with a what you call ideology of giving multis for so many days, and we should come out with muscles should be given for at least 3 कि मैं ये चीज ये कह रहा हूँ, इसलिए कह रहा हूँ कि मतलब कि एज ए मेल डॉक्टर मैं बहुत सी बातें मेरे जहन के अंदर है, बट नोबडी इज कमिंग आउट कि मतलब कि बहुत कम लोग, मैंने असमा से बात की तो असमा ने ये प्रोग्राम अच्छी तरह से ऑर्गेनाइज किया and hats off to Dr. Asma Sultana for organizing a good program. Hats off to all the people, all the presenters over here, जो कि बहुत अच्छा presentation किए, and particularly I would like to what you call सामिया शरीन, बहुत ही अच्छा presentation की उसने और बहुत ही prolonged presentation था, बहुत अच्छा presentation था. तो मैं मेरा अपना एक कंसर्न है कि मतलब कि हुमूल है, पर्दे हैं, और हुमूल कब तक हम किन पेशेंट को रख सकते हैं, पर्दे हम किन पेशेंट को रख सकते हैं. और ये दो ट्रीटमेंट के प्रोसीजर्स है ना, इतना वंडरफुल ट्रीटमेंट है, मतलब कि आप बयान नहीं कर सकते ना. जो सो मेनी डिसऑर्डर इन फीमेल जो कि हम ये हुमूल और पर्दे से हम ट्रीट कर सकते हैं. बट अनफॉर्चुनेटली मैं ये महसूस कर रहा हूँ, ये देख रहा हूँ कि मतलब कि ये जो ट्रीटमेंट के प्रोसीजर्स हैं, और मैं खुद भी मतलब कि मैं वेरिफिकेशन करता हूँ पेशेंट पे जहाँ पर यूट्राइन डिसऑर्डर्स होते हैं, जहाँ पर मतलब कि रेगुलर मेंस्ट्रुएशन पीरियड रेगुलर होता है. मैं टॉप मसल्स के अंदर मैं वेरिफिकेशन करता हूँ, खुद भी करता हूँ. आप सुनकर ताज्जुब करेंगे, मतलब कि आप ऐसे कई पेशेंट हैं, देयर आर हंड्रेड्स ऑफ पेशेंट. मैं अब थोड़ा बहुत डॉक्यूमेंटेशन भी कर रहा हूँ, लेकिन आप सुनकर ताज्जुब करेंगे कि वी आर गेटिंग वेरी एक्सेलेंट रिजल्ट इन ऑर्डर टू ट्रीट ऑल दिस डिसीजेस. और ये चीजें होनी जरूरी है कि मतलब कि हम प्रोटोकॉल्स बनाएं कि मतलब कि किनको मुद्दे दिया जाए, किनको मुद्दे दिया जाए, किनको वेरिफिकेशन किया जाए, किनको हिजामा किया जाए, और किनको नसूल किया जाए, और किनको हुमूल किया जाए, और किनको पर्दे रखा जाए. ये तमाम चीजें हमें डॉक्यूमेंटेशन करनी बहुत जरूरी है. अनफॉर्चुनेटली एवरी इंडिविजुअल इज गेटिंग ऑन हिज ओन व्हाट यू कॉल नॉलेज, और अपना एक उसूल बना लेता है, बना के ट्रीटमेंट करता है. तो वैसे जैसे फॉर एग्जाम्पल मैं एक एग्जाम्पल देता हूँ, किसी बच्चे का ऑस्टियोआर्थराइटिस है, and particularly females are suffering with a lot of osteoarthritic disease. और यह पेशेंट को आपने पेन रिलीवर लिख के दिया, पैरासिटामोल लिख दिया, एलोपैथी के अंदर आपने सुरंजान लिख दिया, माजुने जोग्रंज लिख दिया, माजुने सुरंजान लिख दिया, माजुने चौकी लिख दिया. My question to you people, you doctor, that is it the treatment? Can osteoarthritis cannot be listed in what you call amrazepati? And it's sure it's amrazepati, but why don't you prefer what you call bondage muscle sabri and then give all these drugs? We are not following our own principle. That's why we are losing the patient, we are losing the treatment, we are losing the what you call our glamour. That's the biggest question. Unfortunately, मैं सबसे आपसे दरख्वास्त करता हूँ कि थोड़े से फॉर्मेशन भी मैं शेयर करना चाह रहा हूँ. जैसे अभी डॉक्टर मतलब कि असमा ने एक फॉर्मुलेशन ये किया, मस्तगी रूमी और उसके अंदर जाफरान का इन्होंने फार्मूला दिया. लेकिन एक फार्मूला वो थोड़ा सा मैं रिवाइवल चाहता हूँ मतलब डॉक्टर असमा से. उन्होंने कहा मस्तगी रूमी 1 ग्राम है और जाफरान 1 तोला है. तो जाफरान 1 तोला 1 ग्राम मस्तगी के साथ बहुत ज्यादा हो जाएगा. इसीलिए थोड़ा सा अगर आप एक बार फिर से चेक कर लें, उसके बाद फिर कहें. मेरा एक छोटा सा नुस्खा है, मतलब कि अशोक साल की मतलब कि 1 तोला है और जाफरान 1 ग्राम है. ये इसको दोनों को मुनासिब तरीके से पाउडर कर लें और कपड़ा छान कर लें, आयरन एनर्जी कैप्सूल बना लें और बीड़ी सुबह शाम दे. एंड ये सारे जितने भी ट्रीटमेंट मैं जो कह रहा हूँ ये मुश्किल के बाद दे तो बेहतर है. और उसके साथ अरक़े मको दे, और अगर अरक़े मको के साथ देंगे तो बहुत अच्छा रिजल्ट आएगा. लेकिन दिस कैप्सूल शुड बी गिवन फॉर कंसेक्यूटिव 3 साइकिल्स और 6th डे ऑफ दी और साइकिल से अपने को स्टार्ट करने का ये ट्रीटमेंट. और कंपाउंड ड्रग दे सकते हैं, माजुन मकफिरैन, माजुन सुपारी पाक ले सकते हैं. और तिरियाक़े अरबा का जो रोल है बहुत ही इंपॉर्टेंट है, तिरियाक़े अरबा का रोल. और तिरियाक़े अरबा मैंने देखा कि मतलब कि जितने भी पेशेंट हैं जिनको मतलब यूट्राइन डिसऑर्डर है, रेगुलर मेंसेस है, अगर आपने मतलब के चारों दवाएं मुनासिब सही तरीके से मतलब कि सर्च करके असली में दवाएं अगर बिल्कुल मिलाकर बनाएंगे तो वंडरफुल रिजल्ट है तिरियाक़े अरबा के. अबुलगार है, जिनसियाना मुरमा की ज़रावन तवील है. अब ज़रावन तवील तो यूजुअली मार्केट में नहीं मिल रहा है, ज़रावन मुतरजी ले सकते हैं. और ये चारों दवाएं अगर आपने मार्केट से ली और लेकर अपनी तिरियाक़े अरबा खुद बनाए. एक बात मैं ये तमाम चीज़ों डॉक्टर से कह रहा हूँ कि दवा साजी सीखें, दवा साजी सीखें, दवा साजी सीखें. जब तक आप दवा नहीं सीखोगे, जब तक अपने पेशेंट को सही दवाएं नहीं मिलेगी, सही नहीं आएगा. 1 महीने में 15 दिन में एक दवा बनाना सीखो. और कुश्ते साजी भी जरूरी है, क्योंकि हमारे मॉडर्न मेडिसिन के अंदर जितने भी एक्टिव प्रिंसिपल दिए जाते हैं, मॉडर्न जितने भी स्टेरॉइड दिए जाते हैं, इस हमारी जो स्टेरॉइड है यूनानी के, और वो है कुश्ते साजी. और कुश्ते साजी सीखना बहुत 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 जरूरी है. और ये मैं बात पेशेंट अक्सर ये डॉक्टर अस्मा ने बहुत इम्पोर्टेंट बात कही थी, आयोडाइज साल्ट का इस्तेमाल खत्म कर दें, घर में मोटा नमक इस्तेमाल कर रहे हैं, घर में करड़ का तेल इस्तेमाल करें, और ये सारी चीजें बहुत जरूरी है कि घर में मोटा नमक जरूरी है। क्योंकि आपने ये देखा कि मतलब जितने भी स्टेरॉइड मतलब थायराइड के पेशेंट्स आ रहे हैं, जितने भी ओबेसिटी के आ रहे हैं, जितने भी पीसीओएस के आ रहे हैं, अनफॉर्चुनेटली वेरी अनफॉर्चुनेटली लास्ट 40 ईयर्स 4 डिकेड से आ रहे हैं, 30 ईयर्स से आ रहे हैं। एंड 30 ईयर्स में पहले यानी आप लोग अगर 30 ईयर्स के मतलब की जो 40 प्लस हैं वो शायद जानते होंगे कि देयर इज नॉट सच डिजीज, थायराइड का कोई डिसीज नहीं होती थी, पीसीओएस हमने कभी सुना नहीं हमने 30 ईयर्स पहले। अनफॉर्चुनेटली हम मतलब 1982 87 के हम बैच के हैं, एट द टाइम मतलब कि हमने किया हमारी किताबों में पीसीओ भी नहीं पढ़ा। तो यही बताने चाह रहा हूँ मतलब कि ये जो हम मोटा नमक छोड़कर हमने आयोडाइज साल्ट स्टार्ट करना शुरू कर दिया, क्योंकि आयोडीन हमारी बॉडी के अंदर नेचुरली पैदा होता है, डाइट से मिलता है अपने को, ग़िज़ा से मिलता है अपने को, फूड एलिमेंट से मिलता है, और अनफॉर्चुनेटली वो हम आयोडीन इस्तेमाल नहीं कर रहे हैं, ओरल आयोडीन इस्तेमाल कर रहे हैं, जिसकी वजह से हमारी बॉडी प्रोड्यूस करना बंद कर रही है, जिसकी वजह से थायराइड प्रॉब्लम हो रहा है। स्टॉप इट इमीडिएटली, मतलब कि आप ये जो फ्री फ्लोइंग सॉल्ट होता है ये हमारे जहनों के अंदर थोप दिया गया है, हमारी जिंदगी में थोप दिया गया है, और इसकी वजह से हम सारे प्रॉब्लम में मुब्तला हो रहे हैं। और इसलिए मैं ये कहना चाहता हूँ कि हर बंदे को आपने ये लिख कर देनी है कि सुबह में निहार तक ऑलिव ऑयल 1 टीस्पून या 1 टेबल स्पून 10 ml पीने के लिए कहें। ऐसे जितने भी डिफरेंट डिसऑर्डर्स हैं, थायराइड के प्रॉब्लम्स हैं या मतलब के पीसीओएस है, आपने देखना है मतलब 4 वीक में कितना रिजल्ट आना है। ओनली 1 ड्रग ऑलिव ऑयल दीजिए और इसके साथ इस्तेमाल करने के लिए बोलिए, वंडरफुल रिजल्ट है ऑलिव ऑयल के, प्रोवाइडेड ऑलिव ऑयल अगर असली होता है। और ये चीजें है पोस्टेक स्टार का तस्करा आया था, और पोस्टेक स्टार के लिए हमको क्या करने के आगे तो हमने तो फ्रेश स्टार का अगर पोस्ट निकालते हैं तो उसका जूस निकाल कर हम पीने के लिए कहें, और जूस से बहुत ज्यादा फायदे हैं पोस्टेक स्टार के। और ये थायराइड की स्वेलिंग को, न सिर्फ थायराइड की स्वेलिंग को करता है बल्कि साइकिल को भी रेगुलेट करता है, बल्कि पीसीओएस को भी रेगुलेट करता है। वंडरफुल ड्रग है पोस्टेक स्टार। और जब उसके पत्ते देखेंगे मतलब बर्गे स्टार देखेंगे, आप उसको ओपन करेंगे तो हार्ट शेप नजर आएगा। और मैं थोड़े से ट्रायल भी कर रहा हूँ कि मतलब कि हार्ट डिसऑर्डर्स में भी मैं पोस्टेक स्टार का मतलब जो शानदार दे रहा हूँ। और अशोक थाल बहुत ही अच्छी ड्रग है, और अशोक थाल को बारीक पीस कर उसको अगर आप हाफ टी स्पून में शहद के साथ मिक्स करके खिलाते हैं तो बहुत ही वंडरफुल ड्रग है। एंड अल्टीमेटली एक चीज ये कहना चाहता हूँ कि देयर आर लॉट टू से and lot to do in as far as gynecology is concerned, as far as what is called gynec disorder is concerned, and I request all you people कि इतना बड़ा एक मतलब कि एक स्केच है, इतना बड़ा यूनानी सिस्टम ऑफ मेडिसिन है थ्रूआउट इंडिया थ्रूआउट वर्ल्ड, और मैं ये चाहता हूँ कि मतलब एक आप लोगों की टीम ऑफ डॉक्टर्स उठे, आगे बढ़ के काम करे। और ये जरूरी है मतलब कि दुनिया में जरूरी है कि दुनिया को बताया जाए कि वो हम किस एलिमेंट पे बने हैं, और दुनिया को बताया जाए कि यूनानी सिस्टम ऑफ मेडिसिन क्या है, और दुनिया को बताया जाए कि मतलब कि यूनानी सिस्टम ऑफ मेडिसिन कितना सेफ है, कितना इफेक्टिव है, और कितना मतलब कि ये कहते हैं मतलब कि ये ऐसे क्रॉनिक डिसऑर्डर के अंदर इवन मैं ये कहना चाह रहा हूँ कि आज इस प्लेटफॉर्म देना चाहता हूँ कि अगर आप टेक्निकली साउंड है तो यू विल गेट द पेशेंट ऑल ओवर द वर्ल्ड एट योर डोर स्टेप। आप कैंसर को ट्रीट कर सकते हैं, आप कोई भी डिसीज को ट्रीट कर सकते हैं। yesterday only मैंने एक पेशेंट का देखा मतलब कि उसको मतलब कि एक कंजेनिटल डिसऑर्डर था, और उसने एक हैदराबाद के एक हॉस्पिटल के अंदर एक इंजेक्शन लिया, और उस इंजेक्शन की कीमत 16 करोड़ है। कितनी? 16 करोड़ है उस इंजेक्शन की कीमत। जस्ट इमेजिन मतलब कि हाउ द पीपल आर गोइंग फॉर व्हाट इज एलोपैथिक लाइन ऑफ ट्रीटमेंट एंड व्हाई द पीपल आर स्लीपिंग। हम क्यों सो रहे हैं अभी तक, मतलब कि हम आगे बढ़ेंगे नहीं, मतलब कि हम R&D नहीं करेंगे, हम डॉक्यूमेंटेशन नहीं करेंगे। अनफॉर्चुनेटली मेरी मुझे तकलीफ से बात करनी पड़ रही है मतलब कि नोबडी कम्स फॉरवर्ड। अब अपने प्रैक्टिस के अंदर हम एक 100 रुपए 200 रुपए की प्रैक्टिस के अंदर बहुत ज्यादा खुश हैं, कोई मीटिंग नहीं होती, कोई शीटिंग नहीं होती, कोई सलाम वालेकुम नहीं होती। अनफॉर्चुनेटली मैं कहना चाह रहा हूँ मतलब कि एक हमारे पास एक मतलब कि FUMO के नाम से आपने एसोसिएशन बनवाई। मैं फिजिकली मौजूद था इन दैट एसोसिएशन मैंने प्रोग्राम के अंदर, और मैं बहुत ही अप्रिशिएट किया। ये क्योंकि कोरोना का पीरियड है, मोस्ट प्रोबेबली बहुत से डॉक्टर्स मतलब कि अपने क्लिनिक बंद करके रखे हैं, और बहुत से जगह स्टार्ट कर रहे हैं, क्लिनिक कर रहे हैं। मैं चाहता हूँ मतलब कि अल्लाह ताला से दुआ भी कर रहा हूँ कि इस प्लेटफॉर्म में जितने भी डॉक्टर्स आज यहाँ मौजूद है, अल्लाह ताला हम सबकी हिफाजत करे, हम यूनानी फिजिशियन की हिफाजत करे, डॉक्टर्स की हिफाजत करे, अवाम की हिफाजत करे, उम्मत मुस्लिमा की हिफाजत करे, सारी अवाम की हिफाजत करे अल्लाह ताला। इससे कोरोना पीरियड में. और I am very thankful to all of you people, and I am very thankful to organizer for giving this opportunity. और बहुत बहुत शुक्रिया, जज़ाकल्लाह. Thanks, Asma.
Yeah, thank you, sir. Thank you so much for sharing your views. And inshallah, sir, I do request you to give your support to the FUMO organization. And alhamdulillah, it's good. It's beyond my imagination. The women here are being benefited a lot on the FUMO group, WhatsApp group, where nearly like 250, more than 250 doctors are there, female doctors. So they regularly have the conversation.
मुझे भी ऐड कर दीजिए.
Yeah, sure, sir, sure. So,
Actually,
inshallah, in also.
My wife's telephone, Miss Fatima.
जी सर.
मैं कनिष्क फातिमा की फोन से भी बात कर रहा हूँ. ये भी मेरे बिजनेस की फोन से बात कर रहा हूँ आपको. And this is not my number. My number is 9849139356. You know about it. And I request all you people, organizers, to make a small documentary of this program if you have recorded it, and show it to the people, show it to the doctors, coming doctors and budding doctors, so that they can come forward.
Yeah, sure, sir. We have recorded, sir. Remember the recording is going on. Sir, I'll upload the channel also, the FUMO.
Okay.
And I request also to subscribe our channel to motivate motivators and supporters. In fact, you are supporting the Unani system. You're not just supporting the women calendar or the doctors of the Unani. You are in fact supporting the Unani system. Think that, and please kindly keep supporting. Thank you, sir. Thank you so much. Jazakallah for giving time. Yeah. Thank you all viewers. Thank you so much for sharing your time. Inshallah, we'll soon upload this link, the video over the YouTube. So send in your all group, WhatsApp groups and your contact list. Thank you all.
Thank you, doctors. Thank you, doctors.
Yes, Afifa.
Yes, ma'am.
Yes. And now, bye now. Okay, thank you everyone. Thank you all viewers. Thank you so much.
Thank you.
Okay, Allah Hafiz.